Hello, I'm Mark Clemens, and you've been watching the Fifth World Consensus Conference on BIA-ALCL. We're going to do a bit of a transition at this point in the program, and we're turning now to our fifth session, which is completely online, completely virtual, and really focused on patient education. This is our patient education session. Dr. Santanelli and myself really struggled with only having 2 days to fit in everything new that's been happening about ALCL. And so this year, for the very first time, we came up with the idea of doing a half day at the very end of our conference just devoted to extra information on ALCL. This enabled us to do a deep dive into patient education, as well as some of the newest research that's being performed on the subject, and just to be able to take a deeper dive into everything that we've wanted to show in the past, but sometimes we've had to make editorial decisions that we just didn't have enough time for it. Now, much of this content was actually driven by patient advocates asking for specific information to expand on. Other areas were key aspects that we haven't been able to focus on in the past just due to time constraints. And this year, we're finally able to give an entire full half-day experience. I know it's been a long 2 days with the main conference. Hopefully, you'll either continue to watch this or you can use it as a library to come back to for your own reference. With that said, I want to turn it over to the patient education session. Thank you so much.
I'm going to talk about the process of breast implant-associated ALCL. I'm going to talk first about how to establish the diagnosis of breast implant ALCL, which starts with suspicion of the disease, and then how we do the handling of cytology, flow cytometry, and pathology, and then discuss if we really need all those testings. Then I'm going to talk about when breast implant ALCL is not the diagnosis. That is because there are other lymphomas which arise also in the capsules, as well as other neoplasias such as squamous cell carcinoma and other disorders which are also associated with breast capsule. So what is well established in breast implant ALCL that we all know is that is a CD30 positive T-cell lymphoma, usually presents as an effusion, less frequent as a mass, and sometimes with enlarged lymph nodes. The pathologic staging is crucial and essential, as well as the assessment of margins when the specimen is resected. Why? Because a positive margins results in high rate of recurrence or progression of disease if left undiagnosed. And then that leads to the proper clinical staging and management of the patient. So this is an example of effusion. We can see here the implant, which is distorted, surrounded by an effusion, which has been resected and blocked. And this is an example of a case presenting with mass, and you can see here the MRI seeing a mass. The PET-CT shows several areas of enhancing, which indicates infiltration, and this is the en-bloc resection, and we have an ink the margin. Subsequently, we take sections and proceed with pathologic staging, which consists in assessing what is the tumor. If this is the capsule, the tumor cells appear here on the surface. We call this pathologic stage T1. When there are some few cells start infiltrating and there is an inflammatory reaction around, we call T2. And when this is deeper, we call T3. And when they infiltrate of cells, we call pathologic stage T4. And then on the right, we can see all the brown means CD30 positive cells. So on the pathologic stage T1, the neoplastic cells are only on the surface, eventually start progressing a little bit, and this is a T2. And when it's deeper, we call T3. And when the neoplastic cells are beyond the capsule, we call pathologic stage T4. In this particular case, we can see the ink and the deep margins, and we can say that the margin is negative, so the tumor is not infiltrating the margin. When we receive the specimens, it's essential to do an adequate grossing. So we require from our surgeons that the specimen is oriented with sutures denoting the superior margin or the lateral or median margins, and we palpate the specimen to see if there is any fluid, so we aspirate and send for processing. Then we open the capsule sequentially in different axes, and then we get exposed the implant, and then the implant is removed and the capsule remains, and we make additional sections to have this flat and get it fixed. So this is after it's fixed, and then we ink the margin with several colors to keep the orientation of the specimen, and we take several sections. Initially, we proposed to take 2 sections per side, about 2.5 centimeters per section. So this is 5 centimeters here, 2.5 on each of the other side. And we submitted 6 cassettes for each side of the specimen. And some people were complaining it's too many sections. So more recently, we're not sending 6 cassettes, but we're sending 2 or 3, which contains extensive large sections of the capsule where we make a roll and put in a cassette, and we can that way have an extensive sampling with just 2 or 3 cassettes. And that obviously is saving some expenses. And we published this procedure in modern oncology. Now, what do we do with the cytology? The cytology, the problem is that sometimes you can have a lot of neoplastic cells, but sometimes inflammation looks very necrotic. There are many inflammatory cells, and then it's difficult to call a diagnosis of malignancy because you just have very few neoplastic cells. And then you try to resample then the specimen, the cytologic specimen start having a decrease in the number of neoplastic cells, so there are less and less every time. And then sometimes when you open the specimen, you don't see a lesion really identifiable. The lesions are not really, right now, they appear. So what is the minimum amount of fluid? Again, there is not consensus, but in general, 2 or 3 or 5 mLs are very little of fluid, and that's usually considered not pathologic. In general, less than 10 is not pathologic, but we can aspirate 10 to 15 mLs, and that is probably an adequate volume that we can distribute for cytology. We give them 15 mL so they can do smears and cell block. So this is in general, let's say we have a 50 mLs, we get 15 for cytopathology, they do smears and cell block. We send 15 mLs for flow cytometry so they can do the T cell markers and CD30. And we still have 15 mL we send for molecular testing for gene rearrangement of the T cell receptor to see if there is clonality. Again, this is not the standard. Many places don't do it. You see the neoplastic cells already demonstrated by other means you don't need, but sometimes it can be very important. So it's very difficult to say don't do it. If we can do it. So this is the cytology, how it looks like large neoplastic cells in a cell block. They're still large. With CD30, you can see how they are highlighted as here. By flow cytometry, if the laboratory has an established testing for CD30, then it can get the neoplastic cells there. But sometimes, if they don't have this marker in their panel, then the diagnosis can be missed because the neoplastic cells are very large, usually fall in the area of monocytes, and then that is the area where we avoid testing because the area of lymphocytes. So the question always is, do we need all that? Well, you know, if clinically suspicious, either because the clinician thinks it can be or the patient has a strong feeling it can be, there is no other alternative than doing as much as possible. Certainly, if there is cytology and there is good amount of effusion, we do all the testing, send for flow cytometry. And again, as we say, T-cell receptor gene rearrangement, again, there is not a definitive role for this testing, and we use it. Sometimes it's positive, it supports the diagnosis. And finally, we try to be very careful with the handling of histology. So this is, for example, a case of a patient with a thickened capsule, had a little bit of thickening of the capsule, and this was initially evaluated and looked like a lot of fibrosis with some few cells, and this case was not tested for. My colleague pathologist says not necessary, but certainly we received the case in consultation, and then we review that, and we say maybe we should try CD30, and in fact there are many CD30 positive cells. So again, sometimes the clusters of neoplastic cells are so small that we don't want to believe that this is a tumor. This is another case which was also missed because there is the capsule very fibrotic, a lot of inflammation. When we look high power, you say it's necrosis. But when we do CD30, there are cells here on the surface. It's a T1, it's a pathologic T1, but in fact, this case was not diagnosed. And 3 years later, the patient presented with a large mass here in the capsule, and this is pathologic stage T4. And here we can see how the CD30 highlights the neoplastic cell within the capsule, so it's an invasive. We try to study these cases. So in our series, there were 70 cases. We refer that there were previous biopsy or previous fine needle aspiration or previous cytology. And then we say, well, let's retrieve those. And in fact, of 70, only 10 had the capsule or the fluid was examined. 60 cases did not process the cytology. 60 cases did not process the capsule, anything. So there is no evidence what happened the years before. But in 10 cases, we were able to see that of those 10 cases, 3 remained the same after 3 years follow-up. So they were T2, and 3 years later, they still were T2. 5 cases progressed from T2 initially to T4 3 years later. So there is a progression, and 2 remain about the same. They were T4 at 1 year later, they still were T4. So they were already invasive. Of these 10 patients, 2 died because they progressed from T1 to T4 while the disease was not diagnosed. So again, that's not cannot be extrapolated very much, but certainly it tells you that there is progression. So you let it alone, and we publish this in Oncology also. Now, are there other diseases which associate with the breast implant? Certainly, there are other lymphomas which have a recent associated with the implants and the capsule. There are B-cell lymphomas such as diffuse large B-cell lymphoma, marginal zone lymphoma, extranodal, TNK, EBV positive, or EBV positive large B-cell lymphoma, as well as more recently, there are more than 20 cases of squamous cell carcinoma already diagnosed. Squamous cell carcinoma certainly is not that you do a stain and you find it really, the capsule is thick and we can see this nest of carcinoma cells clearly infiltrating. It's not like you do a stain and you see, wow, I discovered a squamous cell carcinoma. No, in fact, there is a lesion. It's not like you see a normal capsule and then you find a surprise. There are other diagnoses on breast capsules, and then again, the usual complications, which again is estimated about 30% with breast implant have complications. Many of them have the need to repair by surgery, like rupture of the implants, contracture, effusions, which are not breast implant ALCL, or complications of the acellular dermal matrix. And certainly, there are other processes like breast implant illness, which again is recognized by some and not recognized for others. So it's controversial. Again, there are non-neoplastic complications. We have some few examples of a seroma, looks like a breast implant, the fluid here, but in fact, when we see the cytology, they are just lymphocytes, some macrophages, and we examine the capsule, is almost no cells, almost no inflammatory cells. All that you have is synovium on the surface. This is clearly benign. This is not breast implant. And I wouldn't do the CD30 here. If I do CD30, I won't find anything, because there are no cells to test. Maybe there is one cell here, one little cell here, but that's not what is ALCL. This is another example of a ruptured implant, and you can see how the implant has been ruptured and the gelatin inside from the silicone is outside. And this goes through the capsule and this appears like clusters of jello. And then when you see the cytology, there are a lot of reactive small lymphocytes and macrophages which are phagocytizing silicone. So again, the question always is, how about the markers? The markers for breast implant ALCL. Well, you know, the markers don't make a diagnosis. Let me tell you, if we check some markers, CD30, we say, oh, B-cell markers like CD2079 or keratin, or let's put the microscopy. This is us, the skill of a pathologist as a marker. For every disease, like breast implant ALCL, for example, we will see an ablation. For every lymphoma, we will see lymphoma cells. For squamous cell carcinoma, we will see carcinoma infiltrating the capsule. For reactive process like seroma, we will see what? Synovium, silicone, inflammation. Again, CD30 positive, then when it's breast implant ALCL, when we see an ablation. When we see B-cell lymphoma, we see B-cell markers. Again, we see lymphoma cells. And when we see carcinoma or squamous cell carcinoma, is positive for keratin, but certainly we don't do just blindly. We see in the case of the carcinoma. Again, if the specimen looks reactive and everything is negative, we don't do anything. And again, to emphasize, ALK is negative in all. So there are no diseases in the breast which are ALK positive, and there is not a need for them. So we are almost the time. And so in conclusion, breast implant ALCL is a diagnosis can be straightforward, but there are several presentations which can lead to misdiagnosis and progression of disease. There are emergency entities like new lymphomas, squamous cell carcinoma, reactive process seroma contracture, which again bring morbidity to patients affected with choosing implants. Thank you very much.
Good morning. Thank you very much for giving me to Fabio Santanelli to give me the possibility to have this interesting intervention about the BIA-ALCL lymphoma and the implication, the psychological implication about this delicate type of lymphoma. Also, despite reconstructive surgery is secondary to other treatments, this type of intervention is very, very important to the well-being of the patients. The breast implants are conducted in order to restore body image, self-esteem, and femininity. And of course, this type of intervention has a very important implication on the sexual and relation well-being of the patients, and so on the psychological well-being. The data of in the world about this specific type of lymphoma due to the implantation, breast implantation, the data are very different in the world. And in the single countries. In the American Society of Plastic Surgeons report approximately 1,300 cases of this type of lymphoma. The European Association report 511 confirmed cases, and in Italy we have only 105 confirmed cases from 2010 to 2023, including 2 reported deaths due to the lymphoma. So we can see on this data that the prevalence is very different in the world. And in Italy, we have a very little prevalence. So we have to understand what is the meaning about this little prevalence in Italy. And this could be due probably to the difficulty to report all the confirmed cases that probably could be more than only 105. And so the problem is the attention of the single countries, like Italy, probably, to report with precision all the confirmed cases in order to find a possible solution of this problem that has so important psychological consequences. Then we know about the breast implanted woman experience for all the type of consequences. 50% of these women reported some complication about the post-surgery. But what happened from a psychological point of view when a woman that reported this implantation and this damage, this so bad outcome about implantation? What happened from a psychological point of view? We have very few data about this. Overall, probably because there are very few reported cases, and so it is very difficult to study the psychological implication in this woman, because it's very difficult to identify them. So one problem that we can to take attention is to report all the cases, to find an organization that can identify all these cases. This is the first problem. After this, which are the psychological reaction that a patient can feel after this bad outcome, so with the diagnosis of this type of lymphoma due to the implantation? The first reaction probably is shock and fear, considering that they are conducting this type of implantation in order to resolve a problem about cancer generally, and so they find that this type of treatment causes another cancer. So the stress and probably the effect on this patient is very, very important. It can be a very important impact, psychological impact. So we can, of course, hypothesize a reaction with anxiety and depression, and of course, and we can see also about the experience in the clinical context, we have an impact very important on the body image of these patients, which is what causes this psychological impact on these patients. The big problem is that the patient can see a changing on their representation of the medical institution, from a provider of cures and solution to one of further possible treats to one's life. So the problem is to see a treat in the relationship between between patients and medical staff. So we know how is important the relationship doctor-patients, where the trust in this relationship is very important also for the outcome of the treatment. So when there is a break in this relationship, we can see very important implication on the outcome of the treatment. So what are the possible solutions that we can find in this situation? Of course, is on the clearness, on the clarity that the medical staff can have with the patient. Not only the clarity. Of course, there are 5 points that are reported in the literature, and one is very important is the fidelity. So the problem is to have in mind the important to favor the fidelity of the patient in the medical staff. Another point is to have in mind the important to communicate oral competence on the treatment. Third point is to favor the global trust of the patient in the institution, medical institution. And of course, the confidentiality. So to find, create an environment of trust and security in the patients. We know that all these points are very important, not only for an ethical problem, an ethical question of the medical staff, but also in relation to the outcome of the treatment. So it's very important to have in mind this point. The last one, but not for the priority, is the honesty of the medical staff in front of the patients, where it's important to be and to report all the risk and the option of a treatment with the patient. And it's very important to be very clear and reporting all the possibilities. So also the possible, also if it is not so probable, all the possible risk. And from a point of view of the relationship with the patient, we can imagine that report honestly, so also the possibility of bad outcome can break the relationship with between patients and medical staff. Despite from the previous research, but also the previous experience in the clinical context, we know that this type of break can be resolved in mid and long-term relationship with the patient. So it's very, very, very important to communicate all the possibility to the patient about the treatment. This can, so in synthesis, this can bring a little break in the start after this type of communication, but in the midterm, the patient can consolidate a more important and more solid relationship with the medical staff. In all these situations, so it's very, very, very important to prepare a need for a psychological support in these steps, and that Dr. Virginia Campedelli will explain in this brief oral presentation. Thank you very much for giving me the possibility to report this brief oral presentation on this so delicate problem.
Thank you, Prof, and good afternoon, everybody. Psychological support is important for these women because is essential to address the emotional challenges associated with this condition. And psychologists can help patients to manage stress, anxiety, and depression, or develop coping strategies to deal with all the care process. Psychological support must be characterized by important aspects. For example, to manage cognitive biases, it's crucial to address anything that may make women overly concerned about the risk of this lymphoma and emotionally influence decisions. Helping patients assess the real risk and reviewing decisions together before surgery can reduce emotions that influence treatment choices. Then it's important to focus on the actual risk. Psychological support should help patients understand the evidence-based risk and clinical data on breast reconstruction. and this can alleviate anxiety and lead to decision based on a clear understanding. Then, when exploring motivation for breast reconstruction, it helps to compare concern about this lymphoma with the reasons that lead the patients to reconstruction to improve their quality of life. And this contrast can balance emotions and reinforce the patient's decision. Then it's important to help patients deal with any guilt or responsibility they may feel about choosing the reconstruction, whether if it's for aesthetic or medical reasons, and supporting them in recognizing their needs and the benefits of reconstruction can help alleviate negative emotions. In the end, it's crucial to manage harmful emotions like anger, distrust, or regret well, and because these feelings can disrupt communication with the surgeon or the participation in the screening and the future treatment. Psychological support aims to promote healthy emotional management and improve communication. This approach can help surgeons to rebuild trust with patients and improving the quality of care and patient experience in plastic surgery practice. Firstly, it's crucial to inform patients by providing comprehensive and transparent information. Surgeons can empower patients to make informed decisions about their health. Then, listening to patients is equally important. Actively listening to their concerns, understanding their point of view can help build a solid foundation of trust and communication between patients and surgeon. Then, acknowledging patient concern is a fundamental aspect of their care because it demonstrates empathy and promotes a supportive relationship between patients and surgeon. Then, clear communication is essential to clarify any problems related to breast implants, because if patients have a thorough understanding of their situation, can alleviate anxiety. In the future, it's essential to develop and implement better process for monitoring, treating, and supporting these patients, because in this way, surgeons can demonstrate their commitment to effectively solve patients' problem and improve the overall patient's experience. Finally, what could be the key points to take home? Firstly, recognition and importance of both the emotional impact in women with this lymphoma and the concern about the lymphoma itself in women with breast implants. Then, psychological support is essential to ensure a complete healing process to support women's emotional well-being during all the care process. Then, plastic surgeons must ensure patient-centered care, open communication, and proactive measures to effectively address patient concerns. And in the end, the multidisciplinary approach is fundamental to management of risk communication, diagnosis, and treatment of this lymphoma. Thank you for your attention.
Hi there, this is Dr. Terrence Myckatyn. I'm at Washington University in St. Louis, Missouri, and today I'm going to be talking to you about uncommon presentations of BIA-ALCL and maximizing prompt diagnosis and treatment. Here are my conflicts of interest. So, in my view, uncommon BIA-ALCL presentations include patients that present who don't have a diagnosis of BIA-ALCL until after the pathology comes back, they've already had some sort of breast implant explantation surgery, and then we find out they have BIA-ALCL, or potentially in patients who have persistence of symptoms after explantation and or capsulectomy, patients who present with a mass without a seroma, patients who in fact have BIA-ALCL in the contralateral breast to the one of concern, and then also patients who present with BIA-ALCL with a smooth implant. And just to address this now, what I mean by this is patients who historically have a textured breast implant, but now have a smooth device and then present with BIA-ALCL. To be clear, there are no cases where the history is fully known where a patient developed BIA-ALCL without a textured device. So I think the critical thing here is to make the diagnosis upfront to avoid an uncommon presentation later. Unfortunately, plastic surgeons don't uniformly follow these guidelines to make the diagnosis in a prompt manner. Oftentimes, they don't recognize the fluid or the mass prior to surgery. Sometimes they don't assess the fluid or the mass prior to surgery, or if they assess it, they don't send it for the correct tests. Sometimes they're not actually performing a formal en bloc capsulectomy. And then often they're not actually engaging a multidisciplinary team to help with the management of these patients with BIA-ALCL. And all of these can lead to a delayed diagnosis of BIA-ALCL. So this is just one of our patients. She has a moderate right-sided breast seroma that presents 9 years after placement of a textured device. And just to underscore the importance of making this diagnosis first, aspirating enough fluid, 60 cc's are aspirated here. We recommend at least 10 cc's. Performing an en bloc capsulectomy, recognizing that this is a disease that affects textured breast implants. So this is just a simple schematic. And just to take away from this, the importance of aspirating a fluid collection, or if there's a mass, trying to biopsy the mass before going to the OR, and making sure that you are sending this fluid for cytology, looking for the status of CD30 and ALK, performing flow cytometry on the fluid, and looking for whether there's a CD30 positive cells or not. And then when you go to the operating room, to test the capsule with these tests as well, to test the fluid as well. So what is an en bloc capsulectomy? So for me, this is resection of the entire capsule as a single unit with a margin of normal tissue around the capsule. So this is not synonymous with a total capsulectomy. A total capsulectomy means the entire capsule is removed, but it doesn't necessarily mean that there is a margin of normal tissue around it. That is what you need to do an en bloc capsulectomy. So if that means you have to take out some muscle, some cartilage, some rib, some pec, some skin, in order to truly get a margin on the capsule, that is what you need to do. That is an en bloc capsulectomy. It's not just shaving the capsule off of the adjacent tissue. So in one of the common ways or one of the uncommon diagnoses, pardon me, for BIA-ALCL is to find out that this patient has BIA-ALCL after plastic surgeon has already performed an explantation, possibly even a capsulectomy. So why does this happen? Well, it happens because the diagnosis wasn't made before, whether because it wasn't recognized or there was a failure to properly assess it. But what do you do now? So basically, at this point in time, I would personally engage a medical oncologist on a multidisciplinary team for some further guidance. I would also go ahead and get some PET CT imaging first, just to further delineate and understand the extent of disease as much as you can with imaging. And after I've got that information, I would go back and I would perform a formal en bloc capsulectomy. Something that often comes up is whether or not in an aesthetic patient you can put a breast implant in right away, or in a recon patient put in an implant right away or do a flap right away after performing an en bloc capsulectomy in a patient with BIA-ALCL. And the answer is you probably can in many cases. So this is a nice report from 2019 involving our colleagues from MD Anderson, from University of Toronto, as well as from Australia. And what they found was that essentially for early stage disease, so disease confined to the capsule, they found that it was appropriate to immediately thereafter, at the same operation, place a new breast implant or flap. However, for more advanced disease, so extracapsular disease, they recommend that the patient was clear for at least 6 months before proceeding. And my own institution, our medical oncology team, prefers that we don't put in any implants, not try to reconstruct, regardless of the stage of disease, for at least 2 years after the en bloc capsulectomy. So sometimes what can happen is that the fluid is aspirated, but it's not actually sent for the appropriate tests. So just to review, for cytology, essentially the fluid or the mass is sent, the fluid would be spun down into a block, and the mass or the fluid would then be stained using immunohistochemical techniques, looking for T cells that are CD30 positive and ALK, anaplastic large cell lymphoma kinase, negative. The fluid also be sent for flow cytometry. And this is very important, that the fluid that is sent be done with flow cytometry that's gated for CD30, not CD3. Certainly at our institution, when somebody has a T-cell lymphoma, the standard practice is to gate for CD3, CD3 being a component of the T-cell receptor. However, in BIA-ALCL, the T-cell receptor CD3 is solubilized in a large percentage of cases. So if you go ahead and you do your flow cytometry gated for CD3, as was the case in this patient of ours, you won't find it. And so when we gated for CD30, we noted that that patient was grossly positive and were able to make a BIA-ALCL diagnosis. But this patient went to another lab that wasn't as used to this. And when they initially had their aspiration done, they were called ALCL negative. We had our suspicions. So when we took her back, we resent the fluid, gated for CD30, and found the disease. So this is just here a schematic of CD3, CD30, and the relationship to the T-cell receptor and the cell membrane. So sometimes what can happen is that the patient has an explant, has potentially a capsulectomy, maybe not, but there's no information to suggest that they have BIA-ALCL. So none of the pathology came back. There was no assessment done prior to surgery. So this disease can either recur or persist. Now, of course, if the disease is there and it's not adequately treated, there's a much higher likelihood of advanced disease or and also of potentially needing more advanced treatments. So what happens? So again, you need to get a PET CT to delineate disease, to engage your multidisciplinary team. Once you have their input, sometimes depending on the extent of disease, also input from other teams such as thoracic surgery, then you can go back and perform your en bloc capsulectomy. Sometimes at that point in time, other types of immunotherapy such as brentuximab or chemotherapy may be recommended first. Sometimes a more extensive resection, including chest wall resection, sternal resection, may be recommended in conjunction with your en bloc capsulectomy. Now, analogous to the last one, but what happens if maybe somebody knew the patient had ALCL, but did not actually perform an en bloc capsulectomy? Well, the simple answer is you got to go back and perform an en bloc capsulectomy. But I'd like to make this caveat, and I think many of the plastic surgeons watching this would know what I mean, but essentially you can do aggressive capsulectomy, perhaps an en bloc capsulectomy at the time of removing a breast implant, and for some reason have to go back on that patient weeks, months, years later. And you can actually find, even when there's no breast implant present, that there's this synovial synovial metaplasia, this pseudoepithelial hyperplasia that can develop. And it makes it look as if somebody never performed a capsulectomy when in fact they did. This is essentially the lining of a seroma cavity. Even sometimes with our best efforts, including imbricating sutures and drains, for example, these types of lined cavities can occur, particularly in radiated patients. So I just wanted to make the point that even when people do everything right, remove the capsule, these types of lined cavities can still develop. Sometimes what can happen is that potentially in the community setting where somebody has not all the resources, that they don't engage a multidisciplinary team. And the answer here is to do so, to refer patients on to a center that potentially does more of these cases, has the resources for imaging, oncology, etc., to manage these complex BIA-ALCL patients. What do you do about the contralateral breast? So this is one of our cases. She had a stage 3 BIA-ALCL diagnosed preoperatively on the left. You can see from her PET-CT image that she has a fluid collection. She has this extracapsular area of enhancement. Notably, she doesn't have any fluid or mass at all on the contralateral side. So we went ahead, did an en bloc capsulectomy, resected some additional tissue. Fortunately, we did perform a total capsulectomy implant removal on the contralateral right side. And this patient had occult stage 1 BIA-ALCL confined to the capsule on the right side. So even though we imaged her, we didn't see a mass, we didn't see a fluid collection, this patient was noted to have contralateral disease. So we certainly would advocate for bilateral management of patients if they have bilateral implants, even if the diagnosis is just made on the ipsilateral side. It's also important to recognize that only about 10% of patients with delayed seromas in patients with textured breast implants actually turn out to have BIA-ALCL. So I found that this has always been a useful diagram in conceptualizing what to do about late seromas that Dr. DiNapoli, our colleague in Italy, has previously published. Certainly in patients with atypical cells, where more than 10% of them are CD30 positive, a BIA-ALCL diagnosis can be made. However, if fewer than 10% of the cells are CD30 positive, but there are some such cells, one may consider an incipient BIA-ALCL or perhaps some other non-BIA-ALCL related malignancy. In the absence of atypical cells, depending on the percentage of neutrophils, some sort of an inflammatory response, whether that be acute or chronic, may be considered. It's always important not to miss the forest for the trees when managing the swollen breast, since only 10% of these delayed seromas are in fact BIA-ALCL, and given the fact that a breast can be swollen for many other reasons beyond that. Don't forget about things like the double capsule, breast cancer, congestive heart failure in an elderly patient can present with a swollen breast as well. And of course, the dreaded breast implant-associated squamous cell carcinoma. Oftentimes, a swollen breast implant, of course, people are thinking a BIA-ALCL. However, if this workup comes back negative, they have a PET-CT with this very aggressive appearance, you need to start considering things such as breast implant-associated squamous cell carcinomas, which are extremely morbid with a mortality rate of over 50%, or other types of lymphomas, including these B-cell lymphomas, also developing often in patients with textured implant, often developing with seromas. However, in patients who have different markers. I should also point out that the link between texturing has been made for BIA-ALCL, but has not been made at this point for B-cell lymphomas and for squamous cell carcinomas, just for the T-cell lymphomas. Thank you very much for listening to my presentation. I hope you enjoy the rest of the meeting. Have a great day. Thank you.
Dear patients, I'm Dr. Sorotos. I'm going to speak to you today about Centers of Excellence, accessing knowledgeable and experienced treatment teams. These are my disclosures. Let's define what a Center of Excellence is. Center of Excellence in healthcare refers to a specialized facility or program within healthcare organizations that demonstrate exceptional expertise and capabilities and outcomes in a particular area of medical practice or treatment. These centers are typically distinguished by their focus on a specific specialty, or like in our case, on a specific pathology like BIA-ALCL. What are the characteristics of such a centers of excellence? It has to be specialized. It has to be a center where the pathology is recognized and treated regularly. There should be expertise by all the team members, and the center must be well prepared in diagnosing and treating patients with such pathology. The facility should be top-notch. We should have, for example, in BIA-ALCL, a pathology department that is very well prepared, and a radiology department that is very well prepared. And we should have a multidisciplinary team. We should include all the specialists necessary to deal with such pathology. So, for example, in BIA-ALCL, an aware plastic surgeon, oncologist, hematologist, radiologist, and of course, a pathologist that will help us with the diagnosis of the disease. Then the center should be involved in research. This is a very important thing. For example, in pathology such as BIA-ALCL, where research is changing the view we have on this pathology yearly, these centers should be involved in research and should be updated with new research. Then outcomes should be offered, and they should be able to be evaluated. Evidence-based practice are very important, and this goes together with research, guidelines that should be followed. And of course, it should be a center that is patient-centered, and this is very, very important for diseases such as BIA-ALCL. But now let's see how we can research, how we can find a center of excellence. We can do that by doing a simple search, and we'll see that, for example, if we look for BIA-ALCL centers of excellence in the US, MD Anderson comes first. We can see that we can find further information, for example, on our website regarding the International Breast Surgery Workshop or the World Consensus Conference on BIA-ALCL, where resources can be found. Once we do that, we have to go and look for the credentials of the Center of Excellence. And we can do that by checking, for example, on PubMed. We can see if we go on the advanced query box, we can find that the affiliation MD Anderson and the title and abstract with BIA-ALCL will give us all the manuscripts that are published by the MD Anderson on BIA-ALCL. We can see that we have 46 manuscripts that are published. And if we check that with the overall production of BIA-ALCL in the literature, just by doing a simple search, and this is very, very generic because, for example, initial manuscripts were not referring to BIA-ALCL as BIA-ALCL, we are able to find, for example, that currently in literature, there are around 420 manuscripts. So 46, 50 out of 420 is a good number to establish that MD Anderson is a great center of excellence. Also, patient advocacy groups are very important. They help a lot with information, with initial support, guiding patients towards centers of excellence. It happens very frequently with BIA-ALCL. So it is very important to their role, and they can really be very, very useful in the initial stages of a diagnosis for patients. Now, the next step would be to schedule an initial consultation with the Center of Excellence, and we can discuss with the treatment team, evaluate the expertise, the experience, and the approach of the healthcare providers. It is very important to emphasize the collaboration that there should be between the members of the team. So we should be able to see that the plastic surgeon will speak to the oncologist and the radiologist and the pathologist in order to have a multidisciplinary approach to our pathology. This is something that can be done once we visit the center. Now, we've seen what a center of excellence is, how we can define it, characterize it, and look for it. Let's see why it is important. And I will do that by presenting some cases we have to deal with in the past. So this is a very standard case of BIA-ALCL, a woman that came to us in June 2019. It was a woman with 76 years old with a history of radical mastectomy, expander implant reconstruction with a textured implant 15 years before, the standard case. She came to our center for recurrent seromas. As you can see, her right breast is swollen. We did a classical approach, fine needle aspiration, cytology analysis, and we always do a microbial culture in order to exclude an infection. We found that she had BIA-ALCL, so it was a classic case of BIA-ALCL. So we went on to do a pre-op evaluation of the patient with a PET scan, and it was clean. And we were able to do straightforward surgery by removing the whole capsule and the implant together and send it to pathology for confirmation of the diagnosis. This is not all about this case. Let's go back and look at the history of this patient. In 2004, she had a Mentor Silter expander that was later switched to an Allergan BioCell implant in 2005. In 2008, she had implant replacement for rupture in a very specialized cancer center, not a BIA-ALCL specialized cancer center, but a cancer center. So she had implant replacement, and they only performed a partial capsulectomy. The pathology result of this 2 centimeter specimen was granulation tissue, this small capsule, a piece of a capsule. So 1 month later, she had recurrent seromas, and they did multiple aspirations, fine needle aspirations to empty the breast, remove the seroma. So the end was thrown away. No cytology, no microbial culture was done. So she came to us a year after that, and we diagnosed BIA-ALCL. So this patient if we go back to our histology, our capsule, it confirmed the diagnosis, of course, and we found that it was an R1. So tumor cells were found in the posterolateral surgical margin of the capsule, external margin of the capsule. So she had to receive radiotherapy in order to complete her treatment and have a negative PET scan due to an R1 staging. This is a case that exactly explains why a center of excellence is important. We published this case in and also plastic surgery. Let's see another case. 2013, April 2013, 13 years after implant, patient has cold seroma. That was 2013, 2 years after the FDA announcement of BIA-ALCL, really close if we speak about awareness. So the patient had total capsulectomy and breast implant replacement. The surgeon was aware of BIA-ALCL, but it was too early. Not so many cases were out, so there was not already a standardized procedure on how to deal with seromas. So the surgeon thought it can't be. It is very rare. Unfortunately, cytology confirmed BIA-ALCL on the right capsule. So the patient had to go on extra surgery after this in order to remove the new implant and do a total capsulectomy. She had secondary reconstruction with autologous tissues in 2015. A final case of a woman that had an expander, an implant reconstruction, and she had in 2013 a sudden seroma bilateral, but it was not a very important seroma, so it wasn't really evident in preoperative views of the patient. She underwent a bilateral implant replacement with Silimed implants and Polytech implants on the left breast. So the fusion that was found during surgery was sent for cytology, and BIA-ALCL was diagnosed. So 1 month after symptoms, we had to go again back into surgery and do breast implant removal with total capsulectomy. And pathology confirmed ALCL on both capsules. In conclusion, I would like I believe that we should continue our journey towards excellence. And in order to do that, we need to establish multidisciplinary teams, invest in research in order to have more centers of excellence that offer patient-centered care. Thank you very much for your attention. Thank you very much for following the 9th International Breast Surgery Workshop and the 5th World Consensus Conference on BIA-ALCL. I hope we'll see you next year in April in US, and stay tuned. Thank you very much.
Hello, and thank you for the opportunity to present. I'm Megan Fracol, and I'm an assistant professor at Northwestern Memorial Hospital in Chicago. Today, I'll be giving an update on when to consider other lymphomas and implant-associated cancers. So I think the audience is pretty familiar with what breast implant malignancies are at this point. They're associated with the capsule. We think they're secondary to chronic inflammation, and previously they were associated with texturing, although we're still trying to figure this out with some of the newer malignancy categories. There are three main types that we're currently aware of. The most common of these is breast implant-associated anaplastic large cell lymphoma, which is a T-cell lymphoma. But more recently, in September of 2022, the FDA announced a link between breast implants and two other categories. These are the B-cell lymphomas and squamous cell carcinoma. So today I'm going to review differences between these three. ALCL has been around since the first case report in 1997. The FDA made an announcement linking breast implants to ALCL in 2011, and today there are over 1,300 cases reported worldwide. The B-cell lymphomas are different from ALCL in that they represent a heterogeneous group of B-cell lymphomas, not just one type. There's 9 different types that have been described. Diffuse large B-cell lymphoma is by far the most common of these, and most of these are positive for Epstein-Barr virus. Now, the World Health Organization recently reclassified these as fibrin-associated diffuse large B-cell lymphoma. So you may start seeing the acronym BIA-ALCL, which is quite a mouthful, but I'll explain how they came to this categorization. So there are 3 types of diffuse large B-cell lymphomas not associated with breast implants, but 3 types that I want to review here. And this helps to explain how the World Health Organization came to classify these as fibrin-associated. Now, all of these are Epstein-Barr virus associated. So EBV positive diffuse large B-cell lymphoma, the first subtype, is very aggressive. It has both nodal and extranodal presentation with very aggressive systemic symptoms and therefore requires aggressive treatment with chemoimmunotherapy. Now, chronic inflammatory diffuse large B-cell lymphoma is also EBV positive, but it's its own separate category because of its clinical presentation and that it tends to involve specific anatomic spaces. The most common example of this is pyothorax lymphoma. So this typically arises about 30 years after the presence of a chronic pyothorax. This is also very aggressive, very poor prognosis. Now, fibrin-associated diffuse large B-cell lymphoma used to be considered a subtype of the chronic inflammatory diffuse large B-cell lymphoma. However, this most recent World Health reclassification separated it out into its own category because clinically it acts very different from chronic inflammatory diffuse large B-cell lymphoma. Unlike chronic inflammatory, it is not aggressive. It is very indolent. Because it's indolent, it's often incidentally found. But like chronic inflammatory diffuse large B-cell lymphoma, it does involve specific anatomic spaces. Typically, it's found at sites of fibrin deposition. So this can often be found in association with things like prosthetic valves. Now, this is more similar to what we think the breast implant-associated diffuse large B-cell lymphomas are because they are found in the capsule, so an anatomic space, and they're more indolent. So they are much similar in clinical presentation to these. So now, whereas fibrin-associated used to be a subtype of chronic inflammatory, it is now its own. With. Now, the B-cell lymphomas, in terms of understanding them, we think that they're similar to a post-transplant lymphoproliferative disorder. These are typically arise in the setting of patients with transplants who are on immunosuppression. And typically the treatment for this is removal of the immunosuppression, which typically causes regression of the disease. Similarly, we think that the B-cell lymphomas in the breast implant capsule are associated with the immunosuppressed environment of the capsule, because we know there are a lot of Treg cells in the capsule. Thus, we think the treatment is similar to the treatment of a PTLD, and that the treatment should be removal of the immunosuppression. In this case, removal of the capsule, which is the immunosuppressed environment. And we find that most of these tumors respond very well to capsulectomy, and no further treatment is needed. Now, moving on to the squamous cell carcinomas and our current understanding of them, we don't quite understand where the squamous cells originate from, but we do know that they are in the capsule. One theory is that they may arise from the skin at the time of surgery. Another theory is that they may arise from squamous metaplasia, or transformation of other cells in the capsule. We do know that the majority of cases have squamous metaplasia present, and so that's why this is thought to be a precursor lesion. Now, we do think these are similar in etiology to a Marjolins ulcer, and that they're secondary to long-term chronic inflammation. In terms of cases to date, I'm going to talk a bit about the MD Anderson experience, and then also worldwide. So ALCL, we have 77 cases we've described at MD Anderson, but 1,300 cases worldwide. The B-cell lymphomas, we've either treated or given second opinions for 14 cases, with 42 cases worldwide. And the squamous cell carcinoma, we've seen 3 cases at MD Anderson, but 31 cases worldwide. In terms of demographics, average age is pretty similar for all of these patients in their 50s. Now, what's different about the lymphomas is they tend to favor the reconstructive population a bit more than the cosmetic population when you look at breast implantation rates. So in terms of like the profile registry, about 60% of cases are cosmetic, whereas 40% are reconstructive. And this is higher, favors the reconstructive population compared to the rates of breast implantation, where it's closer to 75% cosmetic, 25% reconstructive. Now, part of the reason for this is that BRCA patients seem to have maybe a shorter time to onset, and we do know that JAK-STAT signaling can be affected with the BRCA gene mutation, and we also know that JAK-STAT signaling is maybe an underlying pathway in ALCL. So maybe there's some connection between the two, although this has not been proven. The squamous cell carcinomas, however, tend to mimic breast implantation trends, at least in the US, where 3/4 are happening in cosmetic patients and 1/4 are happening in reconstructive patients, which is similar to the rates of reasons for breast implantation. In terms of implant characteristics, the lymphomas have a much shorter time to onset of about 15 years between implant placement and onset, whereas the squamous cell carcinomas occur much later, closer to 25 years after implant placement. Now, I'm counting time from first ever implant placement, whereas some reports will count most recent implant placement, so you may see shorter numbers in those reports. One question is it a texture problem? With ALCL, we know that they've only been described in patients with a textured history, where complete history is none. For both the B-cell lymphomas and the squamous cell carcinomas, the vast majority are in patients with a history of textured devices, close to 90%. However, both types have been reported in patients with a history of smooth implants only, although this represents the minority. For the B-cell lymphomas, the diffuse large B-cell lymphomas have only been reported in macro-textured devices specifically. Another question that came up is it a rupture or silicone bleed problem? I don't think this is the case, because these have been reported in cases with saline implants only. Also, just of note, the squamous cell carcinomas have been reported in 3 different cases in the setting of liquid silicone injections, which I don't think has been reported with the lymphomas. In terms of symptoms, ALCL most commonly presents with a seroma. The B-cell lymphomas also are very similar in that they often present with a seroma, but there are a good percentage of patients, 1 in 10, who are asymptomatic and incidentally discovered. Again, this is similar in line to the fibrin-associated diffuse large B-cell lymphomas, which are frequently incidentally discovered because they're very indolent. The squamous cell carcinomas are totally different in that the vast majority present with a mass. So here's several pictures of squamous cell carcinoma presentations. You can see the upper left-hand corner is actually a male with Poland syndrome who had an implant placed for that, and he presented with a very large mass. You can see there's also been patients who presented with draining wounds, skin changes, and ulceration. In terms of staging at diagnosis, both of the lymphomas are again similar in that they tend to present early stage, with the majority of patients, 60 to 70%, localized to the capsule. The squamous cell carcinomas, however, tend to present more delayed, with 70% having invasion beyond the capsule. Because the lymphomas tend to present earlier and because they're more indolent, often surgery alone is adequate for treatment, whereas only 1/3 of patients have been treated with surgery alone in the squamous cell carcinomas, and most of these patients require adjuvant treatment with chemo and radiation. In terms of outcome, the B-cell lymphomas, again, very indolent, similar to ALCL. The vast majority of patients have no evidence of disease at most recent follow-up. There were 3 patients who have recurred after initial treatment, but we all suspect these patients had reasons for recurrence. So 1 patient never underwent implant removal, and we suspect that was an ongoing stimulus for disease. 1 patient refused chemotherapy despite recommendations, and then 1 patient did undergo surgery but was delayed in treatment, and she eventually was adequately treated with an autologous stem cell transplant. The squamous cell carcinomas are unfortunately different in that they have very high recurrence rates and rates of death, actually. 50% of patients who've been followed do recur. Of those with adequate follow-up too, 1/4 have died of disease and 1/4 have ongoing disease with very poor prognosis. This is a patient we treated with squamous cell carcinoma. She had a history of prior breast cancer, treated with bilateral mastectomies and implant reconstruction, and she presented years later with chest pain. Imaging workup showed a mass that extended from the posterior aspect of the capsule down to the mediastinum. She underwent en-bloc resection and unfortunately was found to have positive margins involving the pericardium, so she was not able to have a complete excision, and she was being treated with palliative radiation at most recent follow-up. In terms of the workup of these patients, any patient presenting with implant-related symptoms a year or more out from surgery should undergo imaging, ideally with ultrasound and mammogram. Now, if there is fluid present, that fluid should be aspirated. If there is a mass present, that mass should be biopsied. And there are various markers that help guide next steps. We know that markers for ALCL include CD30 positive and ALK negative. We know that common B-cell markers include CD20 and Epstein-Barr virus. And if squamous cells are seen, staining for P63 should be done. One thing I do want to make note of on this slide is that it's possible to see squamous cells on fluid aspiration, but that does not allow you to distinguish between benign squamous metaplasia and invasive disease. So if you see squamous cells present on fluid aspiration, you need to either biopsy a mass if present, or you need to get tissue samples from the capsule in order to determine if invasive disease is present or not. Once you have a diagnosis from your pathology, I'd now like to talk about various treatment options. So for ALCL, this is typically treated with complete capsulectomy, and as long as there's no mass invading beyond the capsule, we typically recommend just no tumor at the inked margin. Now, we have found that it is safe and reasonable to perform immediate reconstruction with smooth implants. In terms of additional treatment after surgery, if you can get a complete excision, then no further treatment's necessary. However, patients who either have incomplete excisions or advanced disease that involves lymph nodes or other sites, then we recommend systemic therapy with chemo at that point. Radiation is really only reserved for palliative cases. The B-cell lymphomas are very similar in terms of treatment. A couple differences that I want to point out on this slide. First is that we do recommend testing these patients for immunosuppressed states such as HIV, hepatitis, and Epstein-Barr virus, given that B-cell lymphomas in general can be seen in immunosuppressed states. Another thing, similar to ALCL, we recommend just no tumor at the inked margin. You do not need any sort of wide extensive margins, given these are relatively indolent. However, we are not currently recommending immediate implant-based reconstruction, given that there have been a few case reports in patients with smooth implants only, and we still are not completely understanding if these are only seen in textured devices or not. Thus, we would recommend delayed reconstruction in these patients only. Now, the squamous cell carcinoma, the treatment regimen is a little different. Because these are very aggressive and because they tend to involve invasion of the chest wall, typically this requires involving thoracic surgery and making sure that tumor margins are much wider. So you want at least 1 to 2 centimeters of tumor margin. Likewise, we also do not recommend immediate implant-based reconstruction in this patient population. Most of these patients will require adjuvant treatment, given it can be difficult to get negative margins on these patients, and many of them have more advanced disease at diagnosis. There's been a number of different chemotherapies that have been tried. I will say anecdotally, there have been a couple cases that have responded well to Keytruda, so I think that is something worth considering in these patients. So in summary, the ALCL and B-cell lymphomas behave very, very similarly. They tend to be indolent and tend to be adequately treated, usually with surgery alone if it's early stage disease. But the squamous cell carcinomas, unfortunately, are much more aggressive and require much more aggressive treatment as such. I do want to emphasize that the B-cell lymphomas and squamous cell carcinomas are newly emerging classes of disease, and we really encourage any providers who are seeing these cases to please report them to the profile registry to help us track these cases and to help us get a better understanding of how they should be treated. I do want to emphasize that the treatment recommendations I'm presenting today are very preliminary, and these will change as more information becomes available about these rare tumors. And these are my references. Thank you so much.
Thank you. It is a pleasure to be here today. In my role as Principal Investigator of the Profile Registry, my goal today is to share with you both the origins of this rare disease registry and our findings to date. I have no financial conflicts of interest. As noted, I am the Principal Investigator of Profile and currently serve as the co-chair of the National Breast Implant Registry. So you may remember back, now over a decade ago, it was January 2011 when the FDA released its first safety communication warning of the association between breast implants and anaplastic large cell lymphoma. When the safety communication was released, 34 cases were known worldwide. Patient tracking was being performed at a very few academic centers, and there was no patient registry that existed at the time to report or submit these cases. And the FDA itself then warned at the time that their own MAUD database, or medical device related adverse event database, had some limitations, significant limitations, including the potential submission of inaccurate, unverified, and or duplicate data. And thus it was determined that there was a real need to create an infrastructure where detailed data pertaining to cases of ALCL could be housed. And so as a result of the subsequent collaboration between these entities, between the FDA, the American Society of Plastic Surgeons, and the Plastic Surgery Foundation, the Profile Registry was born, and really in broad strokes was designed to simply better understand the relationship between breast implants and ALCL. So in 2011, it was designed to collect both past and future cases in the United States alone. And really, we wanted to collect complete and consistent data elements needed to evaluate factors associated with this very new entity. And then, of course, just over a decade later, the FDA released its first safety communication regarding reports of squamous cell carcinoma and other various capsular lymphomas. And following this safety communication, Profile opened up its inclusion criteria, and now the Profile Registry captures data on cases of BIA-ALCL, implant-associated squamous cell carcinomas, and other capsular lymphomas. So where are we at today? Well, since October 2011, since the inception of the registry, 423 distinct cases of BIA-ALCL in the United States have been reported to Profile. In addition, 5 distinct cases of BIA-SCC in the United States have been reported. Of these cases, 256 reporters have then completed complete case report forms, submitting granular level detail on these cases. If we look at the number of cases of BIA-ALCL diagnosed per year over time, we can see that the majority of reporting certainly happened after that first FDA safety communication, which likely indicates just improved awareness and testing for the disease. Interestingly, we can see that cases appear to peak in the year 2019. Cases dip following that, likely related to the COVID-19 pandemic. Cases increasing somewhat again in 2022, but last year the number of cases reported to Profile dipped again. This interesting paper published in 2021, led by Evan Matros, looked at the TOPS database. The goal of this paper was to use database elements to characterize national trends in rates of smooth versus textured implant utilization, with their goal to being to predict a time horizon which the number of new annual cases could be anticipated to peak. So TOPS data was queried from 2007 to 2019 and used or looked at codes involving breast implant use in both augmentation and reconstruction. You can see that on the graph on the left, the orange bars represent smooth implant utilization. The blue bars represent textured implant utilization. And the curve on the right really hones in on textured implant use over time. And you can clearly see that usage peaks in 2016. Looking at macro versus micro-textured usage, macro-textured is represented by the green bars, micro-textured by the purple bars. And you can see that it's almost evenly split with a slight increase in micro-textured usage over time. So based on this data, then the authors predicted that, well, it's a median time horizon of 10 years before a patient may develop BIA-ALCL. And based on this, then the peak number of cases might be anticipated to be in 2026 or thereafter. And so an interesting proposal, and certainly one that we will keep a close eye on over the next couple of years. For those who aren't familiar with the workflow of Profile, there are several unique characteristics of the registry. The first one being that we, at this time, accept physician-reported cases only. And the idea here is that we are able to capture complete, consistent, and high-quality data related to each case. We have a Western IRB, which will satisfy a majority of individual reporters. We collect patient health information, and using that health information, we are then able to screen for duplicate entries. And based on this, we can confidently say that our number of cases represent unique cases in the United States. Once we have agreements signed and we have ruled out duplicate entries, submission is now using a web-based format with smart capabilities. So where has this led us? Where are we at in total? Well, looking at our data, 99.6% of patients were female. There is one transgender individual in our database. The overwhelming majority of these females were white and non-Hispanic. 62% of patients in the database endorsed a medical comorbidity. The most common comorbidity being a prior cancer history. And of course, not surprisingly, the most common cancer was a prior breast cancer. Notably, 3 patients in total had a history of a prior lymphoma, 7 patients having another malignancy. Looking at patient surgical history, 57% had a cosmetic augmentation, while 43% had implants as part of post-mastectomy reconstruction. Honing in specifically here on that reconstructive cohort, 96% of these patients had bilateral implants. 89% had a multi-device history, having undergone 2-stage reconstruction with tissue expanders. 18% completed chemotherapy and 8% completed radiation. The average time to having implants was 11 years, with a range of 2 months to 40 years. That patient who had a history, or a diagnosis rather, of ALCL after 2 months had a history of prior implant usage. 60% of patients had a silicone implant, nearly 40% had a saline implant, and of course, as to be expected, nearly 98% had a history of a textured implant at the time of diagnosis. There are patients in our registry who were diagnosed in the presence of a smooth implant. So looking closer at these cases, we know that the majority of these patients did have a history of a prior textured permanent implant or a prior tissue expander and textured permanent implant. There is one case with a history of prior textured tissue expander only, and one case in which documentation would suggest that a patient had a smooth history only, but at this time, the documentation cannot be verified. Looking at ancillary procedures such as ADM placement and fat grafting, only 13% of patients had a history of ADM, while 6% had a history of fat grafting, suggesting that neither of these procedures may predict nor protect against the disease. Clinical presentation. Interestingly, nearly 1 in 10 patients had a history of systemic symptoms at the time of presentation, the most common systemic symptom being night sweats. 94% had local symptoms. As you might expect, the most common local symptom was a new seroma, but interestingly, just over 1 in 4 patients had a new capsular contracture. We do have patients who have bilateral ALCL in the database. Interestingly, 3 of these 8 patients had bilateral symptoms, but 5 patients presented with unilateral symptoms and were diagnosed with bilateral disease only after pathologic evaluation. Annual follow-up data is collected on all patients in our registry. We have a response rate of approximately 60%. In 153 reports at a mean 2.2 years after diagnosis, the majority of patients here have no evidence of disease. We are aware of 3 cases of persistent disease in patients who did not agree or did not undergo appropriate surgical therapy. We are aware of 5 cases of recurrent unilateral disease, and we are aware of 7 deaths. These 7 deaths represent 2.8% of our total cohort. 5 of these cases succumbed to metastatic ALCL. 1 patient died due to metastatic breast cancer, and in 1 case, cause of death is unclear. So what are the highlights? What can we see from the 10,000-foot view? Well, this accumulation of data allows us to say that nearly 1 in 4 patients presented with a new grade 3-4 capsular contracture, and nearly 1 in 10 patients presented with systemic symptoms. Notably, 6% of cases were asymptomatic at the time of diagnosis, and approximately 5% of patients were diagnosed with smooth implants in place. Over 50% had a history of multiple permanent implants. 1 in 10 patients had a positive axillary lymph node. Fat grafting and ADM use was used in a minority of patients. Our bilateral cases do support those NCCN guidelines for bilateral surgical therapy in patients, and complete surgical therapy is, of course, necessitated. Looking now at the first 4 submitted cases of BIA squamous cell carcinoma. These occurred in 4 white non-Hispanic females. 2 of these patients had prior cosmetic augmentation, 2 had implant-based reconstruction. 1 of these patients had not only a history of breast cancer, but prior Hodgkin's lymphoma and was noted to be gene positive for BRCA. 3 of these patients had saline implants, 1 had exposure to silicone implants, 2 had exposure to textured shell devices versus smooth shell devices. The time from most recent implantation to squamous cell carcinoma diagnosis was or ranged from 5.9 years to 16 years, with an average of 9.4 years. No cases reported ancillary fat grafting, ADM, or mesh use. 3 of these cases presented with swelling, 2 with breast pain, 2 with masses, 1 with a capsular contracture, and 1 with axillary lymphadenopathy. The duration of symptoms lasted 3 weeks to 2 years. It seems that with these cases, we are honing in on the needles, if you will, in the haystack. But I think it's important to know that this profile database has really been shown to be an essential tool to unify the collection of data and build a comprehensive knowledge base, not only about ALCL, but now will continue to do so regarding SCC and other capsular lymphomas. Because of this uncommon nature of these diseases, it is important that we collect granular level details of these cases in order to understand their etiology, their epidemiology, and their pathogenesis. Improved data harmonization with other international registries will advance this understanding going forward. And I think it's important to not only keep engaging physicians, but also patients alike, in order that we can increase reporting and increase our understanding of the importance of registry data as it pertains to the real world. Thank you.
Ladies and gentlemen, dear patient and colleagues, I'm going to present you the screening of the BIA-ALCL and how to manage the patient with texture implant, asymptomatic patient, which is the most important group that we pay attention now. These are my disclosure. So asymptomatic patients with textured breast implant, but do they really exist? Because it's reported by several papers that patients with texture implant, they refer having different kind of complication and symptoms. The most common are seroma, capsule contracture, double capsule, breast pain, but also other less common like breast itching, breast rashes, arrhythmia, autoimmune disease, breast implant shape change, modification of the breast sides, and so on. We have so many symptoms. So hardly we can say that there are really completely asymptomatic patients, but most of the patients with texture implant have at least one of those symptoms. But let's consider the asymptomatic, those with the less common, less frequent, less important symptoms. So the National Comprehensive Cancer Network guidelines that were updated in 2024 include as main signs associated with the disease BIA-ALCL, the presence of an effusion, the seroma, the enlargement of the breast, the presence of the mass, and sometimes also in advanced stages and ulceration, but also others like lymphadenopathy, skin rashes, capsular contracture. So all those symptoms usually present after 1 year from implantation, but their mean time of presence is about between 7 and 9 years after the implantation. So we have to understand how to study those patients when they come with symptomatology like that, they can presume to be connected to BIA-ALCL. So we have to start our workup with breast ultrasound that give the possibility to study the presence of an effusion with 5-needle aspiration or the presence of a mass with a biopsy. And with that, we can do the further studies like cytology, looking for CD30 and ALK, or cold culture also for pathogen, which should be always done. In case this is inconclusive, the study with the ultrasound, then we have to go for more study like the MRI, which can be in cases where it's not conclusive, of course, but MRI should be offered in order to study better also the condition of the implant, if there is a rupture, failure of the implant, and if there are masses around the breast or lymph nodes. Patients with T-cell lymphoma like the BIA-ALCL may have also extranodal disease, which may be inadequately studied by CT scan. And for those kind of specific patients, you need to undergo PET scan. So a very interesting work about the imaging and validity studies and modalities was done by Adrada and colleagues, and they aim at describing the imaging findings of patients with BIA-ALCL and determine the sensitivity and the specificity of detecting the presence of an effusion or a mass, which is the two main characteristics of the disease. So for sensitivity, we have to consider a true positive rate, the capacity of this study to detect the true positive cases in proportion. And the specificity is the contrary, is the capacity of detecting the true negative rate. So is the proportion of negative that are correctly identified. That's a good refresh for the memory of all of us in order to understand the following slides. If we look at the first line study, which is the ultrasound, we said, it is definitely a study that gives you a very high sensitivity on the seroma and reasonably high specificity in the seroma as well, but it's most good for detecting the true negative for masses because it gives a specificity of 100%. So the image that we can see on the left side show a fluid collection between the implant and the capsule. And that's quite easy to detect by the ultrasound. While on the right side, we can see an ultrasound of the upper outer quadrant of the breast with a complex cyst and a solid mass that need to be further investigated. So if we look at the capacity of the CT scan, we see that it's excellent for the specification of the mass. So we can exactly understand true negative mass or true, and it's quite good also for the effusion. Nevertheless, we can see that the image that we see with the CT scan clearly detect this mass in continuity with the capsule periprosthetic. And the real value is in detecting this locally advantaged mass forming from the disease, which can later invade the chest wall, which is the most important in order to understand the limit of the dissection. So if we look at the PET scan, which is needed when there are some extranodal localization, it shows a very low sensitivity for the effusion. Of course, it's not pathognomonic at all, but it's quite a high specificity for either the seroma and then for the mass. So it should be noted that the metabolic component of the PET scan does not allow determination about the peri-implant effusion, if it's benign or if it's a lymphoma related, because the cell density of the BIA-ALCL within the seroma is too low to get an effective positron signal by the exam. So the image that we see, it shows an image with increased metabolic activity of the same mass we detected in the CT scan, with an uptake value quite high of 27.8. So one more thing that we should note is that although routinely used for other types of lymphoma, the PET scan is not validated for BIA-ALCL. Although we use it, but nevertheless, it remains among the standard radiologic imaging technique used for patient evaluation, especially for follow-up on the patient in order to detect eventual recurrence. What about the MRI? The MRI shows a sensitivity which is quite low, quite high for the effusion, but low for the mass. And the contrary, the sensitivity of the MRI is quite high. The specificity, I'm sorry, it's quite high for the mass. So those exams basically need to be combined. In the image that we see below, show a bilateral image MRI of the implant and the breast. There is a fat suppression of the exam in order to remove the component of the fat and show the implant with an effusion, and mainly we can see the crenellated appearance of the right implant shell, which may be pathognomonic for a capsular contraction for sure, and also for rupture of the implant. So if we want to summarize this, we can say that MRI has the highest sensitivity and specificity for implant rupture detection. So it's extremely, it's the best, I would say, but it's not 100% sure to detect rupture of the implant, and is able also to discriminate the nature of the implanted prosthesis or the material which is injected. And the sensitivity for cancer detection is not reduced by the presence of the implant. So it keeps those sensitivity and capacity to diagnose the cancer. The picture that we see on the left show a sequence with thick low signal fibrous capsule. So there is a very thick capsule surrounding the implant on both sides. And the picture on the other side here on the right shows a keyhole sign in the left breast, which is the keyhole sign in the left breast, and the teardrop sign on the right breast. Both are pathognomonic signs of implant rupture. Now, if we want to compare and see the strength and weakness of all of the radiology technique we have investigated for BIA-ALCL, we can say that ultrasound should be the first line test for an effusion and the mass identification, also because it can provide immediate sampling by fine needle aspiration. If ultrasound is inconclusive, then MRI is the second line test to be used. In my opinion, thanks to its sensitivity regarding implants condition, MRI should always be offered as a preoperative test before taking the patient to the surgery. Regarding the staging and follow-up, PET and CT scan are the appropriate tests. So we can summarize that in case of seroma and suspicion of BIA-ALCL, the BIA-ALCL is detected with a high sensitivity using both ultrasound, 84%, and MRI, 82%. So those two exams are very important to be run. For presence of a mass, the detection varies between 46 for ultrasound and 64 for PET or CT scan. Something that is very important, it is mandatory before going to surgery, any patient with any suspicious of the presence of a mass or a seroma should be tested before going surgery with those two exams. And possible explanation for this limited performance of this imaging modality can be also lack of awareness from physicians, and the reporting of radiologic information or irrelevance in identifying effusion of mass may not be in the focus of the reported cases in literature. So this is not be taken deep enough on case reported on literature. So we have to sharpen our tools better. So what we know is that since 2021, when the SHARE committee has demonstrated there is a causal relation between texture implant, any kind of texture implant, and BIA-ALCL, and this causal relationship is of a moderate level, those patients with texture implant can be considered patients at risk for BIA-ALCL. We have to be honest and reasonable with that. And the reason why there is this causal relationship is mainly linked, at least in 2021, to the presence in literature of case report, case series, and retrospective studies, epidemiological studies, or small course, but mainly reconstructive patients. So this was a kind of limited level of evidence. That's why it was a moderate level of evidence, but still enough to be confirmed. So comes the point, once we can consider those patients with texture implant as patients at risk. Should we explant or not those patients? So authorities' opinion till 2023 was that either FDA, SPS, and other authorities, they do not recommend the prophylactic explantation in asymptomatic patient with texture implant because there is a low risk of developing BIA-ALCL versus the risk of specific surgery, which is not that well established. There are no evidence, further the authority claimed that there are no evidence that a prophylactic explantation with total capsulectomy or without is a risk-reducing procedure for asymptomatic patients. Then, as there are some cases described that were affected by BIA-ALCL even after removal of the implant, but of course, we don't know if when the implant was removed, there was performed correctly a total intact capsulectomy or not. So let's look at what has happened after those kind of statements by the authority, is that we find out on a long series of cases or two retrospective analysis on prospective database, we could demonstrate with a similar level of evidence, moderate with level 3 of evidence, among 248 cases of BIA-ALCL that replacing the implant is a protective procedure for the patient because reduce significantly the incidence rate for the disease and increase the event-free time. So it postpones significantly the onset of the disease, the replacement of the implant. The use of texture implant in BRCA patient 1 and 2 and TP53 patient should be discontinued. That was our paper of last year because of a significant association with a shorter event-free time. So those patients that have this kind of germline mutation, which are generic for any kind of cancer, the TP53, and for specific ovary and breast cancer, the BRCA 1 and 2, they have an early onset of BIA-ALCL. So we have to consider using not the texture implant in those kind of patients. So prophylactic removal of texture implant, according to what we could investigate with this paper, is relatively indicated. That means that it's not absolutely indicated, but is indicated after a deep, broad, informed consent with the patient and discussion with the patient about the risk of BIA-ALCL and the risk of the prophylactic procedure for asymptomatic patients. That was our conclusion. What we can do is a risk stratification. So what we have done in our study, we took all the risk factors from the event-free time analysis and the survival analysis. We have put them together and gave a score in order to establish a kind of a 3 level of risk for those asymptomatic patients. And one is a low risk if only a 1-2 score, or if they score 3-4, a medium risk, or 5-6 is a high risk. And those scores take in consideration the age when the implant was first inserted, and if there were replacement or not in the patient, when was the surgery, how long time ago was implanted the breast device, and if the patient has a history of breast cancer, what is the genetic predisposition to cancer, and if the patient has a history of seroma or not. So we can stratify the patient. Thanks God, this survival analysis we did is not just done by us, but a separate group, a second group of researchers. They find out the same what we have established. And so they conclude that the implant replacement significantly reduced the BIA-ALCL risk. So it's not only a study by Santanelli and my group, but also by other group from another part of Italy, in Sicily, independently from us, Dr. Vittorietti. So we have consistent demonstration and evidence that the prophylactic surgery can be risk reduced. And therefore, the American Association of Plastic Surgery did an expert consensus panel on BIA-ALCL, and they produced a paper with a moderate level of evidence still, level 3, where they stated some important things. So the use of macro-texture breast implants should be discontinued. So they say we should not use any more macro-texture implants. And they state that asymptomatic patient without symptom, but with macro-texture implant, they have a relative, again, it's important to stress the word relative indication for prophylactic explantation. But when, after an informed discussion between patient and surgeon about risk of having BIA-ALCL and risk of having complication because of this prophylactic surgery. That was a very important statement by a very important scientific society. To this statement, immediately the day after, the FDA reacted with a statement. It's a statement for immediate release. And please do not concentrate with the fact that the FDA claimed that removal of texture implant is not recommended in a symptomatic patient, because you have to read the whole sentence. Of course, it's not recommended per se in a symptomatic patient, but this is the most important sentence from the FDA. However, individual patient means patients stratified per risk should discuss possible benefits and risk of removing those implants with their healthcare provider to make an informed decision about their health. So this is the first time that FDA recognized that can be a risk-reducing role for prophylactic procedure in specific patients, not in all. Exactly what we claim in our study. And we know at the same time, what are those specific risks for surgery? I mean, basically the morbidity risk in any revisional surgery is the same as in a primary implantation. You know, so it doesn't make any difference if you first time put your implants because of cosmetic indication, or if you have to change the implant. The risk for complication is the same. Pain, infection, deep vein thrombosis, premotoric, doesn't make any difference between primary and revisional surgery. And most important, the mortality for this type of surgery, the risk of mortality we have studied along 8 years in 100,000 procedures in Italy, it was 0. So there is no risk of mortality for replacing the implant. So to that statement from the APS, the American Society of Plastic Surgery, similar to FDA, reacted with a statement. And the society employed a methodologist to study our paper and to find what are the limitations of our study, which was clearly explained in the paragraph of limitation of the study. So they confirm what we say, that to demonstrate a high level of evidence for a risk reduction or protective effect of this prophylactic surgery, the analysis would need to include control group and provide a risk ratio between control and patient affected by BIA-ALCL and odds ratio. Of course, we were studying about that, and we made a study about it. And we know, and soon will be published, but you will be able to follow on our Congress what we have presented. And with our study, which is a second level of evidence study, so it's with control group, we can confirm that there is no BIA-ALCL cases in the so-called smooth implants with a texture surface lower than 10 micromillimeter according to ISO 2018. This is, of course, very important. As with this study that we are presenting now and will be soon published, we could demonstrate that BLCL more likely occur in patients that are having a high body mass index. It occurs more often with higher implant volume. So there is a direct connection between implant volume and BLCL occurrence. It occurs more likely in patients with autoimmune and comorbidities disease. It occurs more often in a cosmetic indication compared to post-oncologic indication. BLCL occur less likely, so are protective factors. The history of one or more implant replacement. So we can repeat and confirm again, but at a higher level of evidence, that implant replacement is protective. And post-oncologic patient too is protective, probably because chemotherapy, radiotherapy, and hormone therapy are protective factors for the onset of the BLCL disease. This study, which will soon be published, is a level 2 of evidence. This is the highest possible level of evidence that we can produce for BLCL disease. So, how to manage asymptomatic patient with texture implant? They have, in conclusion, a relative but a growing indication to a prophylactic explantation. We confirm what we have stated in our previous paper, but this relative indication is growing by time as the evidence is growing as well from a level 3 to a level 2. The decision if removing the implant prophylactic should be part of a shared decision counseling, following a broad discussion with the patient about the risk and benefits. So everything should be clearly explained to the patient, either the risk of the occurrence of the disease, either the risk of the prophylactic surgery. So eventually, once you decide for replacing the implant, you can consider, but that does not mean that you must do a capsulectomy or a total capsulectomy, but you can consider it. Eventually, the capsulectomy should be totally intact, of course, but this still remain under clinical judgment. I thank you for your attention.
Hello, everyone. My name is Jillian Gunther. I'm an associate professor in the hematologic malignancy section within the Department of Radiation Oncology at MD Anderson Cancer Center. And I'm so pleased to be with you today speaking about the ray of hope, the role of radiation therapy in the treatment of breast implant-associated ALCL. I won't review the entire breast implant-associated ALCL staging system, but I would like to make a couple of points. Firstly, that the staging system that's used for this disease process is distinctly different than that used for the rest of the non-Hodgkin's lymphomas, as we typically employ the Ann Arbor staging system. And the reason that Ann Arbor is not used for BIA-ALCL is that it does a poor job of discriminating outcomes for patients with different stages of disease. So you can see in this TNM classification, the patients that a radiation oncologist would be more focused on, because we may play more of a role, are those patients with T4 disease, where we have lymphoma infiltrating beyond the capsule, or those patients with lymph node involvement. And so this is the subset of patients that the rest of the talk will be more focused on. The importance of complete resection cannot be underscored enough. And so in this study by Dr. Clemens, we see that patients with breast implant-associated ALCL who underwent only limited surgery had very poor outcomes. And interestingly, of those patients without complete excision, in this study it was 43 patients, the event rates were not different. And so really, even those patients with the most minimal disease still need that complete surgical excision. In terms of patterns of failure, we know that relapse and progression is characterized by local or regional disease extension. And patients that succumb to disease often die due to extensive local regional disease. And that, again, kind of underscores the importance of consideration of radiation for patients with breast implant-associated ALCL after their surgical management options have been exhausted. What are the risk factors for local regional recurrence in breast implant-associated ALCL? We really come to these risk factors by a combination of the retrospective data that we have and expert consensus. And it's generally felt that incomplete surgical excision, disease beyond the capsule, that being stage 4 disease that we spoke about, and lymph node involvement are all factors that increase risk of local regional recurrence. Again, this study looks at those risk factors for local regional recurrence. And in this study, 70 patients, 20% had lymph node involvement, LNI. All of that lymph node involvement was regional lymph node involvement, 93% of that lymph node involvement being within the axillary compartment. This study also shows us the increased risk of lymph node involvement depending on the penetration of disease through the capsule. So of 6 of 49 patients, or 12%, who had capsule confined tumor had LNI, that's distinctly different than 28% of patients who had lymph node involvement if their tumor was beyond the capsule. If we look at patients who have more local regional disease, we see that they're generally treated with aggressive multimodality therapy. So these patients were all treated with surgery, most with chemotherapy, and some then with the addition of radiotherapy if it was felt to be of benefit. A lot of the information, the data, the management of patients with radiation is extrapolated from patients with another entity called primary cutaneous anaplastic large cell lymphoma. And so this is an anaplastic large cell lymphoma that is a CD30 positive T-cell neoplasm, like breast implant associated. And the primary cutaneous variant is typically ALK negative. It has a very favorable prognosis, so 5-year overall survival rates of 85 to 100%. And local therapy is really the mainstay of treatment, which is why more is known in terms of radiation for this entity. So for patients with localized disease, radiation is often considered. There are studies historically showing excellent local control with what we would call moderate doses of radiation therapy, between 30 and 40 gray, but our group has really investigated even lower doses of radiation therapy and shown that the outcomes are still quite good. And so these are doses of 10 to 20 gray, or even perhaps less, which we'll see in just a minute. This is one example of a patient with primary cutaneous ALCL, and this is a very good visual representation of what radiation can accomplish. So you can see in this patient that prior to radiation, she had this large tumor on the back of her neck. Radiation was given. This plan was designed to give 20 gray. And you can see that this is photon-based radiation treating the posterior neck. This plan is designed to spare normal structures, including the spinal cord and the salivary glands. And you can see the effects of this plan as the patient had significant regression on the last day of treatment and complete response clinically 2 months post-radiation. This is another example of a patient that I recently treated with primary cutaneous ALK negative ALCL, and she was treated with just 6 gray of radiation therapy. So you can see this erythematous and hemorrhagic tumor involving the forearm. This was treated with superficial electrons, again, planned to only 6 gray. 1 month after radiation therapy, you see significant regression. And 2 months after radiation therapy, you see what is basically post-inflammatory hyperpigmentation with no obvious residual disease. What is the appropriate adjuvant therapy in breast implant-associated ALCL? In this How I Treat publication, we do have expert consensus to guide us. And basically, there's no established standard approach to the treatment for those at higher risk of local recurrence. And those patients are felt to be those with incompletely excised masses or lymph node metastasis. Patients are sometimes treated with adjuvant radiation or sometimes chemotherapy immediately after their surgical procedure, but other times patients are watched and successfully salvaged with those additional therapies at the time of recurrence. For those with localized residual disease, or if there is incomplete excision, local radiation following surgery is reasonable, and the doses that we typically employ are in the range of 24 to 36 gray. For those with disease outside of the breast, there's often consideration for systemic treatment. The most recent version of the NCCN guidelines gives us some additional guidance in terms of which of the multimodality therapies to employ for breast implant-associated ALCL. And you can see that for patients who have incomplete excision or partial capsulectomy with residual disease, with or without regional lymph node involvement, those adjuvant treatment options should be discussed with the multidisciplinary team. And that's one of the most important points to underscore, as well as the importance of multidisciplinary team involvement in making these decisions. Radiation therapy can be considered for local regional disease, either with or without systemic therapy, if node positive, or if radiation therapy isn't feasible. In terms of the doses of radiation therapy, again, general dose guidelines dictate that 24 to 36 gray is reasonable for local residual disease. Now we'll move on to some cases. This is a 61-year-old woman who status post bilateral breast augmentation. She then presented 13 years later with a right anterior chest wall mass. Core biopsy was performed, and she was found to have ALK negative anaplastic large cell lymphoma. This is a PET scan, and we're scrolling from superior to inferior. You see the FDG avid disease involving the chest wall. Some additional radiographic images show, again, the FDG avid disease on this maximal intensity projection of the PET scan within the right chest wall. You can see on the CT portion of the PET scan, this approximately 5 centimeter mass, and you can see that the disease is FDG avid. This is showing the kind of chronicity of her treatment. So you can see at diagnosis, she has FDG avid disease within the right infraclavicular region. She received 2 cycles of CHOP therapy at an outside institution with good response. And after 6 cycles of CHOP therapy, she came to our institution for further evaluation. There was some question of maybe a slight increase in uptake, which you can see here on the axial image and on the SCOUT PET image up top. But she was recommended observation. And after 3 months, a repeat PET scan unfortunately showed recurrent disease in that location. She underwent a bilateral implant removal and capsulectomy with resection of the chest wall mass and was found to have viable ALK negative ALCL with extensive necrosis. The margins were negative, the capsulectomy was negative, and there were no axillary lymph nodes involved. Postoperative radiation was recommended to the right infraclavicular fossa. The dose was 30 gray and 15 fractions. You can see that this radiation plan is designed to keep as much dose as possible off of her lung and off of her heart. 5 years later, she remains in remission. Case number 2. A 52-year-old woman with a history of breast augmentation 20 years prior presents with left breast edema. She was taken to the OR with local physicians who noted a large fungating growth on the inside of the capsule, which was about 4 centimeters in size. The implant was removed, but the capsule was left in place. Biopsy was performed, which was consistent with CD30 positive, ALK negative, ALCL, and she was referred to MD Anderson. PET-CT imaging revealed an irregular, mildly hypermetabolic mass in the left breast with SUV of 3.8 that measured about 1.6 by 2.3 centimeters. She underwent bilateral capsulectomy with immediate reconstruction and adjacent tissue transfer. Pathology again confirmed BIA-ALCL, 0.8 centimeters on the outer surface of the left implant capsule. Margins were negative. Adjuvant therapy, as we've discussed, there are various considerations. And for her, she was discussed in a multidisciplinary format, and the plan was for observation. And she's in remission many years later. The third case that we'll look at is a bit different. So this woman had breast implants placed in Mexico 10 years prior to her presentation. She experienced some discomfort. Those implants were removed, and there was abnormal tissue noted during the surgery. But the left breast was not healing postoperatively, and a second debridement procedure revealed lymphoma. As you can see in these images, you see a large fungating mass involving the left breast. There's also lymphadenopathy involving the ipsilateral axilla and also the internal mammary region. And you can see, again, this is a clinical picture of what that mass looked like. Here's the patient's PET scan, which showed even further progression from that prior CT scan, again, showing the primary breast mass and lymphadenopathy involving the axilla and internal mammary region. This patient was treated with BV or brentuximab vedotin, CHP, Interim PET CT after 3 cycles showed a decrease in size and avidity of the disease. There were no new sites. The 5-point score was a 4, meaning that there is still questionable residual disease at this time. She completed a total of 6 cycles of BVCHP, and the final PET showed further reduction in size and avidity of the left breast mass with resolution of the axillary adenopathy. And this 5-point score was a score of a 3, which indicates a complete metabolic response. She was dispositioned to radiation therapy with a total dose of 25 gray and 10 fractions. The target was the left breast and those involved internal mammary and axillary lymph nodes. This plan was delivered using VMAT with 5 millimeters of bolus. She was treated using deep inspiration breath hold and placed on an angled board. We'll talk about this a bit more. Here's a look at her radiation therapy plan. So the goals of radiation therapy are to treat the target with leaving other structures alone. And you can see that this plan nicely spares the contralateral breast, the lung, and the heart. This is a look at her dose volume histogram, and I won't get into details, but basically the average doses to the critical structures, including the heart and lungs, were exceptionally low. We employ a lot of modern techniques in our treatment of patients with breast implant-associated ALCL and other lymphomas, but especially in this population, given the good prognosis, we wouldn't want to leave them with a lot of long-term toxicity. And so we employ techniques like involved site radiation therapy, which is targeting only the pre-chemotherapy areas of disease. We use deep inspiration breath hold. We often position patients on an incline board to adjust the breast tissue to move it away from other critical structures. And we also contour normal structures during that planning process so that we can better avoid them with our radiation therapy. Intensity modulated radiation therapy, or VMAT, are advanced radiation techniques that are again employed to help us keep dose off of normal structures. This is giving you an idea of what the benefits of deep inspiration breath hold are. You can see this patient in the free breathing position compared to this patient in the breath hold position. And you can imagine that if we needed to treat breast tissue, that hopefully that radiation would not be covering the entirety of the lung in the breast hold position, as it may be in the free breathing position. This is an example of our patient with a comparison of the free breathing versus the breath hold. And what you can see is that if we have to treat this breast, when the patient is in the breath hold position, that heart is significantly displaced from the breast and allows us a much better chance of keeping radiation off of the cardiac structures compared to the heart's placement in the free breathing position. There are now RT dose constraints specifically for lymphoma on the NCCN guidelines, which are helpful in guiding providers in terms of what should be the goals for organ at risk doses. And with these modern techniques, we can say that doses of 24 to 36 gray are generally well tolerated. There is some risk of treatment-related lymphedema as these patients do undergo surgery prior to their radiation. This is influenced by the extent of nodal dissection, the RT dose and field size, which is, at least in terms of dose, smaller than the traditional doses for breast cancers. It's also influenced by patient factors, including BMI. We worry about cardiac toxicity and lung toxicity, as I've already noted, and we also do take into consideration secondary malignancy risk, especially depending on the age of the patient. In conclusion, breast implant-associated ALCL combined to the capsule is largely curable with definitive surgical approaches, and this is the most important step in therapy. Disease progression and relapse is characterized by local regional pattern of spread, which is why radiation therapy as a local regional therapy is important to consider. Risk factors for disease progression include lymph node involvement, extension beyond the capsule, or incomplete surgical resection. However, the optimal adjuvant therapy beyond surgery really is undefined, and the multidisciplinary conversation on these patients is critical. RT can be considered if localized residual disease or if complete excision is not possible. And RT doses of 24 to 36 gray are well tolerated, especially if given thoughtfully and with modern radiation techniques. With that, I'd just like to thank the organizers, Dr. Clemens and Dr. Santanelli de Pompeo, for the invitation to speak. I'd like to thank our fantastic multidisciplinary team here at MD Anderson for all their contributions to our treatment of patients with breast implant-associated ALCL. Thank you.
Hello, everybody. This is Swami Iyer. I'm a professor of medicine and lead the T-cell lymphoma program at MD Anderson Cancer Center. I thank Dr. Mark Clemens and the organizers for giving me an opportunity to speak on the challenges and solutions for advanced recurrent BIA-ALCL. So these are the four pillars of strength. Obviously, all of advances in cancers today because of the new findings in biology that get translated into the diagnostics of pathology and the availability of novel agents. Nevertheless, there's still the utilization of the traditional approaches such as skilled surgery, radiation, and chemotherapy. So the role of chemotherapy and the novel agents is what we will discuss today in the setting of advanced recurrent disease. So some of the discussion points are the diagnostic optimization. Essentially, BIA-ALCL is a multidisciplinary collaboration with plastic surgeon, the breast surgeon, the hematopathologist, the radiologist, and lab medicine. And there's a huge role for development of biomarkers. And at least in the realm of treatments that we can offer as hematologists and oncologists, the expression of CD30 is important. The availability of clinical study landscapes, such as the checkpoint inhibitors and pathway-driven therapeutics, such as JAK-STAT inhibitors, are very important. So we can talk more about the chemotherapy, the FDA-approved agents, the brentuximab vedotin, and the novel combination in the context of case history scenarios. So these are some of the frontline pathways for you to look at for T-cell lymphomas. The BIA-ALCL, there's a lot been said in this conference. Overall, the prognosis is good. There is heterogeneity, which does affect prognosis, but advanced disease BIA-ALCL and also the recurrent disease invariably ends up requiring multidisciplinary approaches and chemotherapeutic agents and radiation, sometimes very rarely even stem cell transplantation, depending upon the pathology when the BIA-ALCL event manifests itself as a full-fledged lymphoma. So we'll talk about these points through the case scenarios. And one of the things I have to mention this, even though I'm a hematologist oncologist, is one of the instances where we're not always consider every nail to be hammered. And so I think it's important for us to take this thoughtfully and carefully with a multidisciplinary team. One of the first cases that I want to present is a 56-year-old lady with a history of breast cancer who has pruritus in both the breasts. And past medical history, as you can see, has had bilateral mastectomy and received chemotherapy. And a bilateral breast reconstruction with textured silicone implants are being done. Ultrasound shows fluid collection, and the aspiration of the fluid shows a CD3 positive, a CD4 positive, CD38 positive large cells, which is called as anaplastic large cell lymphoma. And no other sites of active adenopathy on the scans. So what are the next steps in the management? Do you do CHOP chemotherapy? Do you do brentuximab? Do you do bilateral capsulectomy, radiation of bilateral breasts, or observation only? And the choices are obvious in this case because this is a stage 1E disease through Ann Arbor staging. And one of the limitations of our current lymphoma staging is that the system does not account for capsular invasion or penetration. That's where the TNM classification that is developed by Dr. Mark Clemens and others includes the microscopic spread of the disease from within the confines of the capsule to capsular infiltration, cellular aggregates, and infiltration beyond the capsule to measure the T1 to T4, and of course the nodal involvement and the metastatic involvement through the TNM classification system. If you look at the management of the early BIA-ALCL, the complete surgery has had the best outcomes. Limited surgeries had poor outcomes. There's been some role for chemotherapy and radiation therapy, but clearly, as you see in this case, both from an event-free survival and overall survival, complete surgery has probably the best outcomes from a 5-year event rate time point. And this has been incorporated in the BIA-ALCL NCCN guidelines for the first instance. And total capsulectomy and excision of the associated mass with the biopsy of the suspicious node, removal of the contralateral implant, and of course, consultation with a surgical oncologist is recommended in those centers that often have to work with in silos, if you will, but the multidisciplinary approach is very important in this case. Obviously, the patient did very well after the bilateral capsulectomy, and was monitored. But you can see in the PET scan that there's a spot that was seen soon thereafter, about 6 months later. So this is an example of, even though an early stage breast BIA-ALCL, which with possibility of recurrence, and the biopsy of the internal mammary node was positive for ALCL from the internal mammary node. If you look at the cell of origin of the mature T cell lymphoma subtypes, particularly the anaplastic large cell lymphoma, ALK positive and ALK negative, they are Th17 driven processes. And it's important that this is kept in mind. And this particular patient chose not to receive anything and was observed and went on to receive cryotherapy. So again, it's not something that is often recommended, but sometimes the choice of a single relapse could depend upon the discussion of the patient and also the possibility of doing radiation, versus in this case, the patient chose to do something out of the ordinary realm, which is cryotherapy. So the second case that I have to discuss is a 68-year-old lady with Allergan textured implants placed in 1997, felt an abnormality in the right breast in 2018 that eventually led to the implant rupture that was removed by the local plastic surgeon emergently. The pathology did not report ALCL in 2018, and therefore no staging workup was done. In 2020, was noted to have a right axillary mass that grew, and now it is 6 centimeters. And the PET scan showed disease confined, as you can see, on the right axilla with the right level 1 and 2 involvement. So what's the next step in the management? Do you give brentuximab alone, or you give brentuximab with chemotherapy, such as CHP? Do you do bilateral capsulectomy, radiation, or observation only? So you can see some of the current evidence-based algorithm. Dr. Roberto Miranda and several others have looked at what happens to patients when they do have recurrence in a scenario such as this. For whatever reason, the microscopic nature of the disease was not evaluated adequately. So with the breast implant-associated ALCL, an analysis of the sequential pathologic specimens of untreated patients actually goes, when you go back and look at these 46 patients that had recurrence, 9 of them had available material. It was found that the stage of the disease was T1, T2, T3, and even 1 with T4, and 8 had undergone complete capsulectomy and achieved a CR. 5 received chemotherapy or chemoradiation, and 1 patient with a stage 4 disease underwent only partial resection and had stable disease with the last follow-up. That being said, the NCCN guidelines for these patients is to consider chemotherapy with brentuximab as a single agent or in combination, and also still a consideration to use non-brentuximab combinations such as CHOP and CHOEP, which we would strongly discourage because the data for the BV-CHP is very strong based on the echelon 2. So the TNM classification again comes to light here, and you have to always stage this. This is a patient with bulky adenopathy in the axilla with the involvement of the node. And you can see that just by the very involvement of the node with any T and nanny or any node involvement makes it a stage 4 disease. And the outcomes according to the TNM stage is very important, both just to remind that the EFS and overall survival in this situation where the approaches using complete surgery followed by chemotherapy and radiation are very helpful. So what do we do for this patient? I just want to emphasize on the biology that CD30 is a hallmark of this disease. It's also a predictive marker because now the line has been drawn in the sand based on the echelon 2 data as shown here, that those patients on the echelon 2 study, which looked at a randomization for patients with CD30 positive T-cell lymphomas that received either CHOP or BV plus CHP. The response rates were very dramatic. The BV is an antibody drug conjugate which delivers chemotherapy faithfully into the CD30 positive cell. The CD30 MMAE, which is the active chemo component, is internalized and released to cause apoptosis in the cells. And the echelon 2 analysis showed at 5 years that the primary endpoint of PFS was and the overall survival was superior in those patients who received brentuximab. So in this particular patient, went on to receive brentuximab plus CHP and is still doing well. What about the role of novel agents? This is another example, a last example of a 40-year-old with bilateral textured silicone implants. In 2012, 5 years later, developed intermittent bilateral breast pain, noted right breast was bigger than the left, and exchanged the bilateral breast implants in 2020 for concern of implant leakage. This did not include a capsulectomy. Since then, symptoms of pain worsened, the right breast enlargement. Unfortunately, due to COVID, the biopsy did not happen until April 2020. So what's the next step in management? So this is already an advanced stage disease, as you saw on the previous scans, and by the algorithm needs chemotherapy, and brentuximab alone may not be sufficient, and you need a combination approach based on the choices. But you can see here, this patient not only did receive a CHP brentuximab, but also went on to receive other chemotherapy approaches because of the massive lesion on the right breast, along with pleural effusion. Finally, after the chemotherapy, underwent right radical resection of the breast tumor, removal of the bilateral implants. And then you can see on the right-hand side that this is behaving more like a full-fledged ALCL with very high IL-2 soluble receptor levels of 10,000. And so she went on to go on a clinical study with a checkpoint inhibitor, pembrolizumab and romidepsin. And we do know that JAK-STAT pathways are perturbed either through mutations or through dysregulation, based on this publication from Lauren et al. And this patient's course is very reminiscent of the JAK-STAT pathway activation. The patient received pembrolizumab, followed by romidepsin, which is a HIT-STAT inhibitor, went on to achieve normalization of LDH and almost a complete response to this therapy within a matter of 2 months. This is the only therapy that this patient has achieved a response. Fortunately, the disease did progress after this and couldn't go on to get an autologous stem cell transplantation. The patient died. So it's just a lesson to show that advanced stage BIA-ALCLs are rare, but nevertheless needs to be treated like an ALCL. This is just an experience presented by one of our medical students, Alexandra Elias, at the American Society of Hematology annual meeting in New Orleans, December 2022, where we looked at about 100 odd patients, and fortunately only a few of them had to undergo chemotherapy, and the overall outcomes, as you can see in the Sankey plot on the right-hand side, are pretty good. Even though the responses are in the range of 90%, there are a few patients who went on to have this response only with chemotherapy. So I will stop here to say that the discussions about BIA-ALCL is generally indolent to localized disease, but in the scenario where it is either advanced or it's recurrent, there's considerations for a multidisciplinary approach, and also choosing a chemo combination with brentuximab that's has to be done in a timely fashion so that the patient can go on to achieve a very good outcome. With this, I'll stop and say that it's important for us to have this communication going beyond our groups that we talked about, and also with the PhD scientists who are discovering new things in the lab. And all these things could not have happened without the help of our very large T-cell lymphoma multidisciplinary group at MD Anderson. Thank you very much for your attention.
For this next lecture, I've entitled it Deconstructing BIA-ALCL, a comprehensive exploration advising patients. As with all lectures, I want to start with my disclosures. I'm the author of Phoenix Rising, Empower and Transform Through Breast Reconstruction, which supports cancer and reconstructive research. I also want to note that MD Anderson does participate in FDA clinical trials for Allergan Mentor and Establishment Labs. And before we get going, I want to acknowledge and thank the patient advocates that were helpful in putting together the questions that I'll be covering in this presentation. Thank you to Jennifer Cook, Terry McGregor, and over 250 patient advocates that are part of the ALCL and Women with Breast Implants BIA-ALCL Facebook online social group. Took these questions, and I've tried to distribute them to many of the other speakers that are speaking throughout the conference, and particularly during the patient education section. It forms the core of this review as well that I'm about to give. Sometimes we have blind spots when we're writing our scientific papers, and it's really helpful for patient advocates to remind us some of the unanswered questions that may linger or may be challenges for patients. And so I'm hoping to address those in this lecture. And so therefore, I want to summarize that I'll be going through several main areas during this lecture. Exploring patient concerns. We'll be covering BIA-ALCL and its presentations, both common and uncommon, diagnostic pathways for atypical cases, surgical and pathological considerations, fluid and capsule testing, management of potential misdiagnoses, patient advocacy and support, and finally, post-diagnosis care and reconstructive options. It's a lot to get through, but I'm hoping that I can answer questions to every single one of these throughout the presentation. Now, I first want to start out with National Comprehensive Cancer Network guidelines, which were updated just this past week on April 11th, 2024. And I want to thank NCCN for approving this and making this available in anticipation of our meeting this week. This has really helped get the most updated information out to you in a timely fashion. And I can say that when we look through these guidelines, these really represent the standard approach utilized worldwide to approach this disease. And it also speaks to the most common presentations, common ways to get a reliable diagnosis, and common treatments. And I'll try and fill in the gaps on where we see some of the uncommon or exceptional cases fall around these. But if we just start out with common presentations, we see that the most common presentation is a large fluid collection developing around a breast implant, usually associated with discomfort, large swelling of the breast. It can cause pain of the chest wall, as well as less common, about 20% of patients having a chest wall mass that they can feel. I'm frequently asked by patients who may get a pathology report back that says occasional or scant CD30 positive cells were encountered, as can be seen in the top patient. That is completely normal. About 1 to 3% of circulating lymphocytes, those are immune cells, will normally express CD30. What we see is abnormally in ALCL on the bottom is that you have confluent abnormal CD30 cells, and that is more of a disease state. So you can see the difference between these two. And a lot of times it's important that maybe this was not performed on routine pathology, and that patients may need to ask for this and just ask for this extra level of testing. We turn to the most common symptoms. We see that effusion, seroma, fluid collection is present in about 70% of ALCL patients. It's characterized by fluid collection surrounding the breast implant. And about 20 to 30% of times you get a mass that forms around that breast implant. And in about 1 in 8 patients, they may get enlarged lymph nodes underneath their armpit. At this point, it's important to do imaging to evaluate for what is going on the inside. For instance, it could just be swelling of the breast. That can be cyclical, that can be normal. But in a situation where there's asymmetries or a large fluid collection, the first line imaging technique is an ultrasound evaluation. In this slide on the top, you can see that's a fluid collection, that black line separated between skin above and implant below. That would be considered abnormal, as well as a mass can also be seen on ultrasound evaluation. On the bottom, that's a large mass that's pushing down or scalloping into a breast implant, also abnormal. Now you have to differentiate this from breast cancer, which can also form breast masses. It affects 1 in 7 women, and it's obviously much more common than breast implant-associated ALCL. So it's important to differentiate between these two. I'm frequently asked if cytology has not been performed on the fluid collection, can you still ask for it after the fact? And the answer is yes, particularly if there's fluid that's left over or saved, or perhaps they do what's called putting the pathology into a cell block, which is a fixed state. Days, weeks, even years later, that tissue can be tested for CD30 immunohistochemistry. I'm frequently asked if it's possible just by looking under a microscope if you can tell ALCL diagnosis, and the answer is most commonly no. It's not able to tell just by your naked eye without any special stains. It usually takes about 7 to 10 days to do the CD30 immunohistochemistry, and so therefore it can't either be determined or ruled out without those special stains. I'm also sometimes asked if the fluid aspiration is ever negative, but then the patient's taken to the operating room and there's disease found in the capsule. While we are aware of a few cases like these are exceptional cases, and we a lot of times don't have all of the information that was involved, or if the proper tests were performed on that fluid collection in the first place. Many times when I review these cases, I see that some of the specialized tests were not performed on the fluid, and that's the reason why they didn't get the diagnosis, only to then perform them later on the capsule. Either way, while no test is absolutely perfect, absolutely sensitive for disease, most of the time, if CD30 immunohistochemistry is performed on the fluid aspiration, it is possible to get a diagnosis at that point. If that is negative, for the most part, patients can usually be assured that they do not have the disease. Surgeons can still biopsy some of the capsule, the normal capsule, at time of removing the implant or exchanging the implant, but we don't necessarily recommend this in the guidelines because ultimately we want to make the diagnosis on the fluid, and if it's negative, we usually treat that as a benign seroma. As we turn to other types of imaging modalities, we have CT scans. They can be useful for assessing extent of a disease or lymph node involvement after a diagnosis is made, but it's not usually a great rule-out test before a diagnosis is made. Really, our optimal test is an ultrasound, but I've included some images where disease was very obvious. For instance, a large fluid collection around a breast implant on the top, as well as a mass sitting next to a breast implant on the bottom. It's even easier to see these if a PET CT scan is involved, because sometimes by your eye, it's hard to tell that that is a large mass, but if we look on a PET CT scan, that actually shows any kind of metabolic activity that's in a cancer, tends to light up very bright. Again, this is our test looking for extent of a disease after a diagnosis is made, but used much less commonly to make a diagnosis. If we turn to MRI, that's our second line of imaging utilized if there's suspicious symptoms. For instance, if an ultrasound is inconclusive, and in this situation, when an ultrasound may be equivocal, is that an MRI can show more detail of the chest wall, might show more symptoms that might be indicative of BIA-ALCL. As you can tell on the top, we have a large fluid collection around a breast implant. On the bottom, we have a thickened capsule, not necessarily a symptom of BIA-ALCL, but suspicious just because there's so much asymmetries between one breast and another breast. MRIs are more expensive, and usually patients have less accessibility to these tests, and it usually requires more time. Therefore, ultrasound, which has the best sensitivity and specificity, is usually our preferred modality. If we turn to mammography, mammography is fantastic in breast cancer, but it really has a limited role in ALCL. And the reason why is that it's harder to see some of the hallmarks that we see with ALCL with mammography. For instance, on the left, we actually see a fluid collection around a breast implant, but it's hardly noticeable. On the right, we actually see a mass from an ALCL, but again, it's hardly noticeable. And it's so easy to miss this on mammography. And so therefore, ideally, you're going to do a ultrasound or an MRI as your primary tools, and really utilizing only secondary tools such as CT scan and PET CT scan after a diagnosis is confirmed. And we talked about some of the most common presentations, but let's cover the less common presentations. Rash, capsular contracture, pain, night sweats. Most of these are occurring in less than 5% of patients, maybe even less than that. And it's important that in these situations, these are highly unusual in that there's many reasons to have these other symptoms. For instance, capsular contracture is very common if patients have a breast implant for a long time. Chest pain might be a pulled muscle or something strained, but it usually is cause for concern and should be investigated if it's unusual or not associated with any physical activity. For instance, a single point chest pain on one side of the chest probably should be evaluated or brought to your healthcare provider. Night sweats, if it's not warm in the room and a patient wakes up drenched in sweat, that can be a symptom of lymphoma, much less common with breast implant ALCL, but still been reported. In skin rashes, particularly skin rashes that develop over the breast area in particular, but as can be seen in these pictures, can happen on different areas of the body. Usually these are evaluated by a dermatologist. In every single one of these pictures, these were actually skin rashes related to a type of B-cell lymphoma, also associated with breast implants. And it can be really challenging when these types of symptoms are encountered to have a high enough level of suspicion that something might be related to the textured surface breast implant in that patient. If these do occur, I would encourage patients to go to their healthcare provider to have this worked up. And also, if they're not getting solutions from the healthcare provider, or maybe they're not used to seeing uncommon things, come to what we call a tertiary center. That can usually be a large hospital or academic center that is more used to seeing unusual type presentations. So if there isn't an immediate explanation of why this is occurring, it is important to maybe get a second or third opinion to help evaluate for what's happening in these situations. I'm also asked about the situation of what happens if the pathology report comes back and it's not that perfect textbook description that I described before. What happens if it doesn't have all of the characteristics of ALCL? Characteristics of ALCL are CD30 immunohistochemistry staining, that's that brown staining on top. We talked about large anaplastic cells. They have unusual morphology. They're about 3 to 4 times the size of a lymphocyte. Also, if this just isn't encountered, but some of those symptoms are, this can be very difficult to rule out, and you have to take into account, is this a different malignancy? Is this perhaps an infectious etiology that's causing this problem? Perhaps this is just a lot of inflammation in the area. Perhaps this is a normal benign process. In these situations, it's important, if there is confusion on your pathologist's part where they just can't say exactly what this is, consider a secondary or a third pathology consultation. Maybe ask for a hematopathologist that may be more used to seeing these diagnoses. And it may require additional tests with other markers. We've talked about CD30 testing, but in these situations where it doesn't really line up with the World Health Organization criteria for ALCL, maybe it should be investigated for B-cell lymphomas or squamous cell carcinoma. And so while it's not part of the primary algorithm to jump to that, if there is confusion, if they're unable to make the diagnosis, if they're seeing something that they just can't characterize, it's probably important for a second opinion and to use additional markers to define what is happening in those situations. So at this point, hopefully we've made a diagnosis of breast implant-associated ALCL. And we begin the treatment phase. The treatment involves getting a multidisciplinary team together to evaluate that patient. It also involves adequate preoperative imaging. We talked about MRI and ultrasound before, but now we're going to turn to extent of disease imaging, and that really requires a PET CT scan. That's looking for lymph node involvement, organ involvement, and it's critical that this happen prior to any type of surgical intervention. If we look at a PET CT scan, it's perfect for determining extent of the disease. And you can see in the bottom picture where a patient had a breast implant, but she also had a large associated mass that was around that breast implant. It was so important to appreciate that ahead of time and to notice that that had that involvement. In addition to that, she had a lot of lymph nodes involved. And so we needed to remove those at the exact same time as the surgery. And so therefore, this type of imaging is critical before any type of surgical intervention is involved. We also talked about a multidisciplinary team that involves a medical oncologist, ideally a lymphoma specialist, and they're going to help define whether there is any need for chemotherapy or not. A surgical oncologist will help evaluate and manage surgical resection, so removal of any tumors, as well as lymph nodes that are involved. And then also a plastic surgeon, a lot of times they'll remove the breast implant itself or help with the surgical resection. A hematopathologist, that's a specialized type of pathologist that specializes in hematologic malignancies like lymphoma and leukemia. They can help confirm the diagnosis and provide details that sometimes a regular pathologist might not be familiar with. Absolutely key in these situations is a early and thorough diagnostic workup prior to beginning effective treatment planning. Collaboration is key between all of these members of the multidisciplinary team, and the surgical approach should aim for complete removal of all of the disease so that there's nothing left, and ideally offer to women for an immediate reconstruction at the time of the resection. When the implant is removed, we usually define it as coming out en bloc or in one piece. That prevents spilling of any of the tissue or the cancer cells within the body. This just demonstrates in these pictures how those specimens are laid out. It's usually laid out flat, and biopsies are performed from multiple different areas of this capsule. Usually 12 biopsies strategically taken from 6 different areas so that we know that the capsule has been adequately sampled and made sure that there's no evidence of disease or that we can characterize the amount of disease that we're finding. For instance, about a third of patients will have no disease in that capsule. Some patients may have early disease penetrating into the capsule, and some patients will have disease that goes all the way through that scar capsule. And that has different ramifications for prognosis, as well as stage of disease, and also some of the extra treatments that may be required for patients. I'm asked by patients, is ALCL a capsular malignancy? Meaning, is it a cancer that arises from the capsule itself? And the answer is no. It actually arises on the surface of the breast implant and in the fluid that is between the breast implant and that scar capsule. So for 1 in 3 patients, we call that effusion limited or a primary effusion malignancy, meaning that all of the disease is just in the fluid around the breast implant. Now, I've been asked, why did we not catch a lot of these cases over the last 20 years? And I have no doubt that those patients that were only isolated to just the fluid collection around the implant may have been treated simply with implant exchange, not touching the capsule. That may have treated some patients. We don't advocate that because we know that 2/3 of patients will have some level of capsule involvement. And so therefore, for all patients with this diagnosis, we recommend taking out the entire capsule that's involved. But again, because 1 in 3 are just in the fluid collection, it probably is possible for some patients to have been treated with just an implant exchange, never knowing that they actually had the disease. Now we can see progression of that disease where we have cell penetration into the capsule, it forms into a mass, it infiltrates through the capsule, and then it can metastasize to lymph nodes in about 1 in 8 cases, and about 1 to 3% of cases going to other organs around the body. That is highly unusual and very rare, but it has been described in bone as well as in liver and in a brain metastasis. And so therefore it is possible, and it is very important to catch the disease as early as possible. In the vast majority of patients, this is a very indolent, or what we mean is a slow growing disease. It tends to progress like a solid tumor, a ball that continues to grow. And because of that, we can treat it with surgery. And in the vast majority of patients, surgery and surgery alone. Now, I wanted to show some pictures just demonstrating where the disease begins. It begins at that implant capsule interface. And in this picture, you can see the scar capsule is reflected upwards, and we see the breast implant surface, that textured surface on the bottom. And it's on that textured surface that the cells begin to grow. And that's the earliest beginnings of the progression of the disease. If we look in these pictures, we've zoomed in on the surface of that breast implant, and we can see that the disease does not start in the capsule, but actually on the surface of the breast implant. In fact, in the picture on the left, I've actually zoomed in using a scanning electron microscopy on a single cell of ALCL growing on the surface of the breast implant. When we talk about treatment of the disease, we usually define it as total capsulectomy, explantation of the implant, and removal of any associated masses, which is usually described as an en bloc resection. That also includes negative margins. We don't need a lot of tissue, of normal tissue around it, but we need some. We need to demonstrate at the edge of our resection that there was no active disease in that area, because that can tell us that maybe there was some disease that was left behind. In this image, you can actually tell part of a surgery that's being performed. There is a mass that's on that breast implant, and it was critically important to remove that mass with the implant at time of resection. You can imagine if that was accidentally left behind, it would continue to grow on the chest wall. Now, ideally, this is performed in one procedure, but frequently at time of implant exchange, they may accidentally get the diagnosis of ALCL. And then they're wondering, can it still be treated with surgery alone? And we do find that usually you can reoperate, you can go back, you can remove extra capsule to get rid of all of the disease. These cases are more challenging in a reoperation standpoint, but it is possible to go back and operate again on these patients afterwards. I want to clearly define the differences between different procedures that can be performed. For instance, you can take out part of a capsule. We tend to do this with capsular contracture from radiation therapy, or when the capsule is misshaping a breast implant. Also, too, you can do a partial capsulectomy if the patient doesn't have ALCL. For instance, sometimes we'll remove part of the capsule And if there's any suspicion or the patient just wants it ruled out, we can still send that for CD30 immunohistochemistry just to test it and make sure that there's no evidence of disease in that. However, that is not treatment. That is not treatment of a diagnosed patient. That's only utilized in situations where we don't think that the patient has disease. Sometimes we perform total capsulectomies, which is removal of the entire capsule. I usually only do this if the capsule can come out relatively easily, where there is not risk of injury of something on the chest wall. For instance, sometimes you can get into the chest wall and actually damage lung. That's called a pneumothorax, or you can damage large blood vessels in the area. And so that might be a reason why you would leave capsule behind. Sometimes it's not possible to resect the entire thing, and you would only do that in a case of actual disease. On the bottom, we see a much more aggressive resection where a lot more tissue is taken out, and it's a lot harder on the chest wall. But that's what we perform in a confirmed case of breast implant-associated ALCL. And you can see in this image with exposed lung at the end of this procedure. We've had one patient that actually had to require a chest tube just because of this type of exposure. And so it's because of this reason that we don't advocate this type of en bloc resection in all patients with a textured surface breast implant. It's much too aggressive of a procedure. There are complications that can be associated with it. And so therefore, we usually only reserve that for a confirmed case of breast implant-associated ALCL. Now, we also recommend that you can perform immediate reconstruction of these patients at the time of when this is removed. And so all of the patients in this series had an en bloc resection and an immediate reconstruction. Our most common type of immediate reconstruction is smooth implants, and that can be considered for both immediate or a delayed reconstruction. Some patients will get utilizing their own tissue, skin, and fat, a flap reconstruction, either a deep or a tram flap. And other patients have been treated with serial fat grafting. So ideally, I find that fat grafting doesn't really work as well, at least in my hands, for a total breast reconstruction, but it can be utilized to help supplement a reconstruction or for minor corrections after a reconstruction has been performed. This just demonstrates our algorithmic approach on how we do reconstructions, and we'll offer immediate reconstructions for early stage, stage 1A to 2A. It's a little bit more complicated in our advanced cases, so stage 2A and above. We usually discuss with the patient benefits and risk, and we might decide to do a delayed reconstruction if we know that the patient still requires radiation therapy or some kind of chemotherapy and has not been completely treated at this stage. I want to focus on some possible reconstruction pitfalls that we try to avoid. For instance, any type of reconstruction, it may increase the chances of complication, and that may affect rates of infection or poor healing, or even dissatisfaction with the cosmetic results afterwards. Also, too, there's always a chance of recurrence of the disease. If the reconstruction is with a smooth surface implant or a deep flap, we don't think that there is any effect on disease recurrence. However, we don't recommend replacing with a textured surface breast implant, as that may affect the ability of the patient to develop the disease again. We also think that it's important, whether reconstruction is performed or not performed, that surveillance is in place to be able to do regular follow-ups, usually on a 6-month or 12-month basis for any patients that have been diagnosed with the disease. And I just want to acknowledge that some patients can develop regret after getting reconstruction. And so I think it's very important to have a deep, detailed discussion about what are the goals of reconstruction. Most patients are very happy with the reconstruction and that they're glad that they did, but we want to make sure that there is realistic expectations, that their psychosocial impacts are addressed, and that they understand changes in their body image with a reconstruction and without a reconstruction. This all requires counseling to make sure that patients understand the risks, benefits, and alternatives of a procedure. I'm part of a physician support network for the Plastic Surgery Foundation, and we have a number of different physicians that answer questions related to breast implant ALCL, and I've seen a number of different types of common questions that are brought up that can be challenges for treating physicians. And so I want to call these out as things to avoid or make sure that you don't do when addressing ALCL. Always test suspicious fluid collections for CD30 prior to going to the operating room. Traditionally, these were just felt to be normal seromas, and a lot of times they may have been thrown away. And it's important that they always go for pathology evaluation. Pre-surgery imaging is an absolute must for a confirmed diagnosis. We really recommend that any confirmed patient see a lymphoma oncologist to help with some of the decision-making of the treatment of that disease. We always aim for a complete resection, particularly the back wall of that scar capsule. That can sometimes be the most difficult part to remove off of the patient, and it's absolutely critical that it comes off in a confirmed case. Prevent spilling of any tumor or any cells during the surgery to prevent spreading of the disease. Always address involved lymph nodes, whether you test them with a fine needle aspiration for any disease, or you excise an involved lymph node at time of explantation. This will help with disease management. And always discuss reconstructive options with patients. I want to turn now to some other implications, which are the financial implications of BIA-ALCL. This was specifically asked for to expand on this by patient advocates. And we just had this prospective paper that was published this past year on financial toxicity in breast implant ALCL, and I was very pleased that we had co-author patient advocates who helped collect some of the data from patient advocates from around the world that have been affected by ALCL. And in this study, we did a cross-sectional analysis of 32 patients. We used types of surveys that detect financial toxicity. What I mean by that is challenges that are faced not from the disease, but from the costs that are associated with the disease. And we found that a small but significant number of patients with breast implant ALCL do have major cost struggles with this diagnosis. And it was correlated with needing radiotherapy or exceeding credit limits, or patients that were particularly dependent on family support for their financial needs. Also, it's important to realize that a lot of patients are traveling across the country, and they may incur travel expenses that are not covered by insurance. And so in general, this is a significant number of ALCL patients. Sometimes insurance has denied claims, particularly when there's a history of cosmetic augmentation. That's improving, but it still is a struggle in patients with a previous cosmetic augmentation, usually requiring a peer-to-peer discussion between the treating physician and the insurance company to try and get coverage of these costs. So I think it's important to be as transparent as possible with these costs up front, so to level set expectations. In this paper, we also called out some different types of insurance companies that have specific policies that say that breast implant ALCL is not covered, as can be seen on the screen, and it's highlighted in yellow, where it was a policy exclusion for a patient that had a previous cosmetic augmentation. And for women that are trying to learn about their textured implants or how to manage them, it's important to check your insurance provider to see if you have these policy exclusions, so that you may want to change your carrier if you're not able to be adequately treated. Because if you're not, there can be significant out-of-pocket expenses, and appeals may improve coverage outcomes, but they're not always successful. For instance, we created this algorithm, which is also in the manuscript, and it breaks down how patients and surgery providers in the United States can go through the appeals process, what works, what doesn't. For instance, we frequently see that a peer-to-peer appeal usually does work in the most number of patients. However, we've also seen some insurance companies will have an alternative called a manual appeal. We have actually never seen the manual appeal ever fall in the favor of patients. And so therefore, we usually recommend patients avoid manual appeals and always choose for a peer-to-peer evaluation. Also, we've broken out what it looks like for secondary external appeals when an insurance company may turn down the first appeal process, and how that can best be found in favor of patients. It's a complicated process, but unfortunately, a lot of patients do have to go through this. I also want to turn to what can patients do that just have breast implants or not affected by ALCL. I think that it's important to still participate in prospective breast implant registries. Now, there is some confusion out there of what is a registry. For instance, I very commonly hear both surgeons and patients say, I participated in a registry because I registered my device. Those are two completely different things. It is one thing to register your device. That is basic breast implant information that is either given by a surgeon to a implant manufacturer, or utilizing an app by a national society to give the serial number information on that implant information. That's actually mandated by the FDA for manufacturers to collect that information. And while that is good, that is simply a device registration. What I'm talking about is encouraging people to actually participate in a prospective registry that is totally different from a registration. A prospective registry actively tracks post-surgery complications. It defines outcomes. It also gives opportunities for patient feedback, and it continues over time, following up and making sure that what are the long-term consequences of those breast implants. An example is the National Breast Implant Registry in the United States. It's a proactive initiation by the Plastic Surgery Foundation, the FDA, and plastic surgery, and it goes beyond mere device tracking, providing comprehensive data on long-term outcomes. Now, there's key benefits for everybody involved here. For clinicians, it can offer valuable insights for that provider, giving them dashboards where they can see their own complication rates and their own trends in their own implant performance. It has major benefits for patients because they have a better understanding about safety profiles of different types of breast implants, and they're better able to make informed decision-making about their own body. And it has clear benefits for research by being able to track these devices, and also ushering in new implant technologies where we see shortcomings with current devices. Again, this is within the United States. There is fantastic examples of breast implant registries in the Netherlands, as well as in Australia, as well as a number of countries around the world. And so I just asked you to differentiate between just registering a device versus actively participating in the research and long-term outcomes as afforded by a prospective registry. For additional information, I would turn you to the American Society of Plastic Surgeons, which has a number of different resources, from informed consent language to understanding data about ALCL. There's a number of different resources for both surgeons as well as patients on this website. Also, for further reading, we've written this paper a couple of years ago, also written with patient advocates trying to answer their most common questions. It's entitled Advising Patients About Breast Implant-Associated Anaplastic Large Cell Lymphoma. And so at this point, I'd like to conclude, which is just to say that early and accurate imaging, particularly MRI and ultrasound, are critical for BIA-ALCL management, and that surgery must prioritize complete resection with en-bloc capsulectomy when indicated. I think that we've also taken a look at uncommon presentation, uncommon symptoms, what patients can do to be advocates for themselves if they don't see certain tests being tested for, and that they can understand why certain imaging and tests are performed in the first place. I think it's important to realize the financial considerations, for instance, financial toxicity, and the significant challenge that ALCL patients have, and to understand current insurance coverage, particularly for cosmetic augmentation patients, which tend to have the most struggles getting these covered. I think it's important for patients to realize the reconstructive options that are afforded to them afterwards, and that it can be performed in an immediate setting, but it really needs to be tailored to a patient's stage and their current preferences. Please stay informed about the full spectrum of ALCL symptoms, not just the most current like fluid collections and masses, but also uncommon symptoms such as night sweats or skin rashes that are not specific to ALCL, but if there's not an obvious answer for why they occur, keep hunting. Go to a second opinion. Go to a center that may see more uncommon things until you get an answer that is satisfactory for you. And that's how we can best address atypical cases. Stay updated. As you can see, so much of this research is brand new and it's constantly changing. And so recheck in on the latest research and guidelines, either through conferences like you're seeing here, through authoritative bodies like the FDA, or your local authority bodies for your respective countries, as well as checking in with your plastic surgery associations, and the standard for diagnosis and treatment worldwide, the National Comprehensive Cancer Network, which we really appreciate as partners, updating their information annually.
Hello, my name is Christina Sajósi. Thank you for having me. I would like to talk about the perspectives on the future of BIA-ALCL as a survivor. So I would like, first of all, to show you how did I look like before surgery. So that was me on the left before surgery after 2 kids. I was thinking I would like to have bigger breasts, so I was thinking about breast augmentation, and the only way I knew was implants. So I contacted 3 plastic surgeons in Hungary, and I was seeing the opportunities. And after my surgery, that's how I look like in the middle. I was competing in sailing. This is vacation on the picture, but I really felt good with my breast at that time. Today, that's how I look like on the right. I think I'm really happy about how I look like today. I would like to remind you about my case. So this is my past. This is me on the picture. When I was thinking about having breast implants, as I said, I went to three plastic surgeons, and I was never informed or warned about the existence of BIA-ALCL. I didn't know anything about it. I decided to have breast implants in 2012, and I got textured Nagar implants. I was really happy. I really liked them. It was so good. They were nice. I really enjoyed having them. I paid big attention to have medical controls every year. So not only blood tests, but either ultrasound or MRI. And I was really careful about my health. I have 2 children. I think it's a must to look after ourselves. So when it was the pandemic period in 2020, I felt really weird and I didn't know what's happening in my body. That's the year when I was diagnosed with BIA-ALCL. Not only BIA-ALCL, but I had bone marrow metastasis also, both stage 4. So they decided to have urgent surgery, removal both side capsules. The implants, I had a walnut-sized tumor, 7 lymph nodes were taken out, and the complete right pectoral muscle. So it was quite a big surgery, but everything went really well. I had 3 weeks healing time, and then chemotherapy started. I got 6 rounds of CHP, brentuximab. In Hungary, governmental approval is needed to have brentuximab, so the Minister of Health had to approve my request. I was really lucky because we knew some people who could help. So in a couple of weeks, the approval was okay. On the 21st of December 2020, I had a paper saying that I'm in complete metabolic remission. So I was really happy about that. I would like to tell you, what did I feel when I got BIA-ALCL, but no one knew anything about it. I was the only person in Hungary who had BIA-ALCL. So they are looking at my case. They were looking at my case really close to understand what's going on in a woman's body. I had big fatigue all the time. I couldn't sleep enough. So I couldn't understand what's going on in my body. I slept a lot, but I still felt fatigue all day long. My right breast doubled size, which was not comfortable at all because I couldn't wear my bra, and it was not nice, and it was weird. Swelling, lots of fluid around the implant. I had pain and tenderness near my right breast, and it was itchy all around the implant. I went to see a doctor in secret during the pandemic, and I had an ultrasound, and he couldn't see BIA-ALCL. He didn't understand what he was seeing, so he said, okay, we have to take out the fluid and it will be okay. I am really grateful, but it didn't happen. I didn't let him do that. because of the bone marrow metastasis, I had really big pain in my hips and in my right arm. That was the thing I was more concerned because it was very, very painful. I had blood tests, not one, but one or two or three or four, I don't remember, and all of them were just really okay, normal values. So even the tumor markers, even the blood test or mammography, they couldn't see, they couldn't understand what they see. So finally, Professor Zoltán Mátrai, plastic surgeon who was leading the department of mammography, or not mammography, sorry, the department of the National Institute of Oncology. He said that I probably need an ultrasound-guided core needle biopsy. So they did it. They made it for making the CD30 immunohistochemistry test and the ALK test. So it became CD30 plus, ALK negative, and altogether with PET scan, they realized that it's BIA-ALCL all over my body. So that was a time when I had urgent surgery and the chemotherapy. What I think is really important, why am I trying to sensitize you? I'm trying to show you what I lived through. It's because of my children's soul. It's because no children should see suffering their mom because of breast implants. I am the only possible mom to them. No one can replace me. Seeing them sad and confused and trying to understand what's going on, if they lose their mom or not, why is it happening? I think it's the worst in the world. So we have children. We want to just save them from pain, and they could see me in pain. They could see me blow. They could see me through the whole process. So yeah, I'm the only possible mom to them. And yeah, last year I realized that it's not only because of my children, but also because of my parents. So I'm the only possible daughter to them. I always say if a father or a mother dies, the child will be half orphan. If a child dies before the parent, we don't have a word for that because it's so unnatural. So I know that my parents, they couldn't live without me. So last year when my father became ill and he was in hospital 3 times, the first time he said, if you could do it, I will do it also. I will be healthy. And he could manage it to come home. The second time he was more tired and he passed away the third time in December. But I'm really happy and really grateful. Not happy is not the right word. Grateful is the right word. That I survived my parents. My heart is broken that my father passed away. But he passed away in the right order. The parents should go first. Today, what I try to show to anyone and everyone is the joy of living. So I'm alive. I became an example to others. They say all the time, if you could do it, I can do it. I am very authentic. I say what they want to know. If they ask questions, I answer. I tell them to focus on their illness. They shouldn't say that my illness is less difficult, important than yours. No, everybody's illness is their biggest challenge. So if I can help, I help. If they ask questions, I am here to help them. I'm telling them also that I really needed my oncopsychologist because I couldn't do it alone. And I became stronger because of her too. I spend a lot of time with my children and also in the nature. I just sit down and I'm just looking at the birds and the trees and water. I need it. I need the presence of the nature. I need to resource from the nature. I love myself more than before. Cancer helped me, really helped me to divorce, and I can admit now that I was not loved. So yeah, that's hard. Today I can love again, and I'm loved too, and it's so magical. I am a free woman, and it's so powerful. I changed profession and I became a French teacher. I love teaching, and I show the world my smile because life is beautiful and we have to enjoy it every day. So now, what can we do about the future? We have a lot of challenges. I am just a regular woman, but I try to summarize a bit what I think about and try to give a try. What can we do together? So I think there are diagnosis challenges. All around the world, plastic surgeons need to be informed about the symptoms so they can diagnose BIA-ALCL. They have to know what they are looking for. Like in my case, they didn't know. I think the treatment disparities, so you know much better than I do, different options at different stages. So there are different medication drugs in different countries. But if brentuximab is needed, women should have it. It would be so important. This is an industry also of money. So there should be a fund where that women who are in need could ask for money. The psychological impact. So we're dealing with uncertainty and fear and the prospect of undergoing surgery, maybe not one, but more, and chemos and radiation therapy. So it's really difficult to deal with it, not only for us, but also for our family members and friends. We need to have support services. So what I said, also financially, emotionally, or counseling. Different countries have different ideas what to eat or what to have, should have vitamins or not. This is also different. And maybe we need more regulation of that on that. We have a super special support group on Facebook, a private group, and so many brave women help each other. I'm so grateful to know them because I learned so much from them. We would love to have a stricter regulated environment about breast implant and much more transparent communication about the risk of implants. The long-term monitoring, I think, is also important because we still don't know a lot about the BIA-ALCL. So patients must be monitored long-term to detect any complications in time. I think we really need to collaborate, healthcare providers, patient advocacy people, organizations, regulatory agencies, and policymakers. Maybe it's too big to say, but we make history now. We make history how to protect women. I think that one of my dreams would be that patient advocacy section should have a place earlier at any conference, or just to have a place at any conference about BIA-ALCL. I think that you need to hear our voices and we need to hear your voices also. We need to meet and discuss ideas together in person. And I think it would be so important for both sides. I think marketing is needed about BIA-ALCL, much more marketing, and find the right channels because we have to inform different age groups. So the much younger people should be finding TikTok or Instagram, and then older, let's say the 30s, 40s, much more on Facebook. There are women's conferences, so we have to find the right place to inform people. Plastic surgeons all around the world should be informed about the symptoms of BIA-ALCL. And we have to educate not only women, but men also. So man can lose a wife, a partner, a mother. So they should know also if there's any problem, what to look for. I'm very happy about the fact that there are different possibilities of breast augmentation, and some plastic surgeons offer already these solutions. Even if I didn't have reconstruction, I think it's really important. So I think advocating is a crucial role is in raising awareness about BIA-ALCL and helping anyone to make the right decision. So that's why we are supporting people. When I had this t-shirt, you always have a choice. I really believe in that. Respectfully, I don't care if someone say it's a rare cancer. It's a cancer. We are still losing women. So please save us when we need you. All my respect, I would like to repeat myself. I am the only possible mom to my children, and I am the only possible daughter to my parents. So please inform and educate women about BIA-ALCL. And pay attention to symptoms because it's so important. I was in a bar in the toilet and there was this written on the wall in Hungarian around the mirror. You're beautiful. Everything else is a lie. And it's so true. So let's help anyone accept themselves as God created us. But if they want breast augmentation, let's help them together to make a thoughtful decision. I'm really grateful and honored you listened to my presentation. Thank you for your attention. If you want to contact me, if you have any questions, my name is Sajósi and this is my email address. Thank you.
Good morning. My name is Giovanni Di Benedetto and the Chief of the Clinic of Plastic and Reconstructive Surgery of Ancona University School of Medicine. I will talk today about the National Consensus Conference on the use of single-use negative pressure systems in the prevention of complications of the incision site in breast surgery, which was held in Rome last September. What is a consensus conference, first of all? Consensus conference provide for analysis of the available evidence on specific and controversial issues on which there is no consensus and which often lead to a strong lack of homogeneity of behaviors at the clinical, organizational, and managerial level of healthcare. A consensus conference is a useful and effective tool able to synthesize what is known and address uncertainties with good clinical practice behaviors. This consensus conference was conducted according to the standard defined by the Consensus Development Program of the US National Institutes of Health. And the methodology followed is also described in the methodological manual, How to Organize a Consensus Conference of the Istituto Superiore di Sanità, published in the National System for Guidelines. Compared to the guideline process, the consensus conference adds some elements of originality, the main one being that the answers of the questions are elaborated by a multidisciplinary and heterogeneous jury, representative of all the different possible approaches to the controversial topic. To arrive at its conclusions, the jury participates in a public assembly where the various experts present the synthesis of the evidence collected in the scientific literature and then leave the participants the opportunity to discuss it. The jury then formulates at the end its conclusions like recommendations. Which is the difference between guidelines versus consensus conference? Of course, there are in the biomedical field a lot of gray areas, which require an effort of analysis, critical evaluation, and synthesis of the available knowledge that represents the starting point of the consensus conferences and guidelines. There is an important difference between these two approaches. The guidelines on one side are an attempt to produce evidence-based recommendations on broad topics involving different dimensions of care on which there are consolidated knowledge. The consensus conferences, on the other side, provide for an analysis of the available evidence of specific and controversial issues on which there is no consensus of opinion and which often lead to a strong lack of homogeneity of behaviors at the clinical, organizational, and healthcare management. Compared to the guideline process, then, the consensus conference adds some elements of originality, the main of which is that the answers to the questions are elaborated by a multidisciplinary and heterogeneous jury, representative of all different possible approaches to the controversial topic. To reach its conclusions, the jury participates in a public assembly where the various experts present the synthesis of evidence collected in the scientific literature and then leave the participants the opportunity to discuss it. The jury then formulates its conclusion in the form of recommendations. And here you have the organizing committee list who's got the different assignments. First, to define conferences objectives, then to find funding, design and plan organized conferences phases, select scientific technical committee members, drafting panel of jury rules, define the questions to be answered by the jury panel, identify experts, and define working groups. Then we have a scientific technical committee called CTS that is composed by 10 to 14 surgeons, one of whom is an expert in the methodology, working on the topic being evaluated. The assignments of the CTS are to collaborate in the drafting of the protocol, to collaborate on the writing of questions, to identify the experts, to define the working groups in collaboration with the organizing committee. Within the CTS, a group of experts will be defined on the basis of their specific expertise in the topics identified by the CP. That in this case will be seroma, hypoperfusion, and the sense of the wound and infection. And here you can see the CTS composition that is made by several experts coming from all over Italy. And you can read here as well from other institutes or hospitals of Italy as well. And here the jury panel that is called G is appointed by the CP, and there's a multi-professional, multidisciplinary composition. The choices in this case are based on criteria of intellectual autonomy, representativeness, authority in the scientific field. G assignment are to define the methodology and procedures to be followed by drafting a specific regulation, to contribute to the drafting of the questions to which each member will help to answer, to analyze evidence documents produced by experts and working groups, and to draft the recommendations that will later become the final document. And here you can have a look at the G composition. Also in this case, the jury composition is made by different experts coming from all over Italy, as you can see here. And further here in this slide, other members of the panel jury. Furthermore, we have making part of the jury, other invited society, all working around problems of breast or other onlus, so to say, such as the Superior Institute of Health of Italy. Then we have the writing committee that is composed of 5 members plus the G president. One of them is a negative pressure expert, and one is a non-medical member, as you can read here in this slide. The consensus conference objectives are to define some clear indications in the use of incisional negative pressure systems by comparing and integrating scientific evidence with clinical experience. During the consensus, available evidence was evaluated in discussing about the following possible complications related to breast surgery, such as seroma, hypoperfusion, necrosis, and dehiscence of the wound, infection. As concerns seroma prevention and management, question 1A was, do you think incisional negative pressure therapy may play a role in the seromas prevention? The recommendation in this case was that negative pressure therapy is recommended for the prevention of seromas. Having 15 favorable votes, the recommendation was approved as strong favorable. Again, as concerns seroma prevention management, the question 1B was, do you think that in order to avoid dead spaces and keep the implant in place, especially in the prepectoral prosthesis, the dressing should wrap not only the incision but also most of the breast? The recommendation was that in this case, negative pressure therapy is suggested to reduce dead spaces, but with less effectiveness on maintaining the prosthesis in place. Having had 1 abstained, 5 unfavorable, and 9 favorable members, recommendation is approved as favorable weak. Second point was hypoperfusion dehiscence prevention. The question was, do you think incisional negative pressure therapy may play a role in skin flap necrosis and wound dehiscence prevention in breast surgery? The recommendation was that negative pressure therapy, incisional negative pressure therapy was recommended for the prevention of necrosis and suffering of skin flaps. Having had 1 abstained and 14 favorable votes, the recommendation was adopted as strongly favorable. Again, about hypoperfusion dehiscence prevention, question 2B was, do you think incisional negative pressure therapy may play a role in the necrosis, the nipple areolar complex prevention? The answer was that the incisional negative pressure therapy is recommended for necrosis, to prevent necrosis of the nipple areolar complex prevention in breast surgery. And having had 15 favorable votes, the recommendation was adopted as strongly favorable. Again, about infection prevention, question 3A was, do you think disposable incisional negative pressure wound therapy may have a role in the surgical site infections prevention in breast surgery? The answer was that negative pressure therapy is recommended for surgical site infection prevention in breast surgery, and recommendation was adopted as strongly favorable, having had 15 favorable votes. Lastly, infection prevention, question 3B, as to concern is the following question. Do you think it is appropriate for the dressing to wrap not only the incision but also most of the breast? The answer was that negative pressure therapy is suggested for the prevention of treatment of possible infection. We had in this case 6 abstained and 9 favorable votes, so the recommendation was approved as favorable weak. Just to have a clarification, the jury panel wants to emphasize that the literature available at the time of evaluation was March 2023 and mainly refers to 2 devices. The first one is PICO by Smith and Nephew. The second one is Previna by 3M. So there can no there can be no certainty that the recommendations produced by this consensus conference can also be ascribed to other devices on the market. The final approval of the document happened in September, and after 2 votes was definitively approved on February 2nd, 2024. Next steps that we preview to further develop are dissemination of results through websites, brochures, and poster creation, scientific conferences, presentations, and other forms of clear and transparent dissemination. I thank you for your attention.